hospital. It's just worth mentioning to the patients that hospitals are safe, or as safe as going on the underground or anywhere else. And I think that's going to be a subsidiary issue that we're all going to be facing.
Thank you very much, David. There's a question for the panel. I think Sachin may be ideally placed, being in a big oncology center. I know in the United Kingdom, the NICE has de-recognized Wismodegib for BCC. The question has been raised: would you recommend Wismodegib for this patient? I know we are running a bit out of time. Thank you.
So from my end, I mean, it was really promising when Wismodegib came in, thinking this is going to be the answer to all these major BCCs. But clearly, with the risk of secondary cancers and the trial just showing that it wasn't efficacious enough, we have stopped funding. The NICE withdrew, and it's no longer funded in UK at least. So we've moved on to surgery and perhaps IMRT as our treatment choices. Unfortunately, there's no chemotherapeutic or immunotherapeutic options yet. Unlike Kemiplimab, which has really revolutionized our SCC management, we are debating whether, if you've got squamous differentiation from BCCs, whether Kemiplimab might be useful. But I think we are so tight with our regulations in where we can use Kemiplimab, we haven't attempted it yet, unfortunately.
Thank you very much.
Move on to the next presentation, please. Can we have the Manchester group side speak on the next case?
While on the subject, Tim, very welcome from Australia to our webinar. Very kind of you to allocate a time on a Sunday. Thank you very much for being part of this. Thank you.
Very happy. Thank you.
Hi everyone, my name is Leshka. I'm from the Manchester Royal Eye Hospital. I'll be presenting a case titled Tip of an Iceberg. So this is the case of an 82-year-old Caucasian gentleman with a previous history of a right lateral canthal and upper lid BCC, which was excised and reconstructed in 2012. It was found to be nodular and infiltrating on histology. The patient was then followed up for 4 years with no evidence of reoccurrence and discharged. He was then re-referred to us last year in September by the GP with a potential reoccurrence noted 2 months prior to presentation. Otherwise, fairly fit and well with a history of hypertension only. So at the current presentation, he was noted to have an elevated pearly-edged ulcerated lesion in the right lateral canthal area. There was also an area of induration inferiorly, and there was adherence to bone. The lateral conjunctiva was injected. The eye movements, however, were full, and there was no evidence of proptosis or globe displacement. So at this point, the patient was listed for an urgent incisional biopsy and an urgent MRI scan to assess the extent of the lesion. The incisional biopsy showed evidence of BCC in the area of ulceration and just scar tissue in the indurated area lying inferiorly. He also had the MRI scan within 1 week of presentation, which showed a lobulated soft tissue mass in the right lateral canthal area. This extended from the skin and wrapped around the lateral orbital margin. There was no evidence of bone involvement on the MRI. The lesion was thought to be abutting the globe and extending just behind the equator, with some involvement potentially of the insertion of the lateral rectus and the inferior oblique muscles. This was an interesting finding because clinically did not correlate so well with the patient having had full eye movements and no globe displacement or proptosis. So we discussed the findings with the patient, and the plan was for a 2-step excision and reconstruction 1 week later. The lesion was excised with a 3 millimeter margin. The deep excision was down to bone. The lesion was stuck to the periosteum, and this was divided. The lateral orbital wall and the lateral rectus were both exposed intraoperatively and were clinically normal. A further area of fibrofatty tissue was also removed from the lateral orbit and sent for histology. The histology showed extensive nodular and infiltrative BCC in the full thickness of the upper and lower eyelids. BCC was also present in the fibrofatty tissue from the lateral orbit. And so the lateral and deep margins were both involved from 4 o'clock and to 10 o'clock. So at this point, we had a further discussion with the patient about options, which included either further globe-sparing excision with a delayed reconstruction. This carried obviously the risk of incomplete excision versus exenteration. The patient was also seen by the prosthetic team and decided to proceed with the exenteration. And this also included a further lateral canthal skin excision with a 4 millimeter margin and a full thickness skin graft from the left inner arm. So the histology of the orbital contents showed widespread multifocal BCC in the lateral orbit. This involved the infra-posterior and anterior lateral orbital soft tissue margins. There was no evidence of any residual BCC in the lateral canthal skin, and there was no involvement of the globe. So at this point, the patient was referred to the head and neck MDT for discussion of further management. And the advice was for removal of bones from the right orbital floor and the lateral wall, plus or minus radiotherapy. These options were discussed with the patient, who declined any further active management. The patient also suffered from a lot of anxiety following exenteration and was referred for psychological support and counseling, to which he responded quite well. He is currently still under observation with us, and there is no evidence of reoccurrence at 10 months following exenteration. So in summary, recurrent BCC can be a challenging condition to manage. It can be difficult at times to distinguish the tumor from scar tissue, and in these cases, clinical photos can be very beneficial. As in this case, we should be suspicious of lesions which are adherent to bone and have conjunctival injection. When these features are present, it's important to carry out further imaging and correlate these to clinical signs. And of course, all management needs to be patient-centered, and it's important to have a frank discussion with the patient about all possible surgical options, including exenteration at the first presentation. We also need to be mindful of the difficult choices that need to be made by the patient and ensure that they have all the adequate support and information that they require, including any psychological support if this might be required. Thank you.
Thank you for that excellent presentation and a very nice management. Let's hear the panelists as to whether they would have chosen a similar management course or would they have thought of some other options. Sachin?
Hi, yeah, Paul, I think this is Paul's case. We've sort of shared a few cases with the Manchester team, and really these are quite tricky. I think Manchester had one case which was one-eyed with a similar presentation, and what do you do? I mean, do you go for exenteration or do you go for staged excision? So similar to Paul and Ashba, we pretty much aim for multi-staged excision in the first instance. If you can get clearance, then that preserves the patient's vision and globe, though he may have other side effects. So that's our first go-to attempt, really. And if we can't clear, then we go for a exenteration or super exenteration. Perhaps I potentially would have taken the lateral wall at the same time, but that's sometimes it's a discussion to have with the patient, and some patients just prefer, you talk about major craniofacial resections and they don't like the idea. So, you have to take that into consideration.
What has your experience with radiotherapy been?
We've got, depends on how extensive it is. What we find is that at the moment the tumor extends beyond one quadrant of the orbit, you've got sort of lateral, the orbit and inferior orbit involved. Even if you try IMRT, you're pretty much condemning the patient to lifelong restriction movements, severe side effects from the radiotherapy. So we have to really, weigh the benefits and the side effects. So sometimes patients prefer, rather than, it's something that we do, but we have to be very mindful that it's still not yet targeted. And often you have these perineural invasion, which escapes the radiation field. And your priority is to try and prevent the tumor from spreading to the brain. So it is adjuvantly useful, but it's a double-edged sword.
Any comments from any of the other panelists or
I
anybody?
think it's important, like when you start to see conjunctival injection or tethering, and in this patient, the question by the GP was whether or not this was all just scar tissue and a progression of scar tissue, or whether there was something else new going on. But it definitely looked like there was something new going on, and that it was possibly a recurrence. So in that instance, that's why we got the scan done, and we wanted to do the biopsies to confirm, because at that stage, you really want to give the patient as full a picture as possible of what the possible pathways and treatment options are going to be. And you know, if you don't have it planned or you don't have your biopsies, then you're not really sure what you're going to be doing. So even from day one, we were talking about exenteration. Now, this was a patient who was, although he was 82, he was a carer for his disabled wife. So he was quite an active man, and he didn't really want that whole uncertainty. He was actually quite, I suppose, it's not uncommon with these types of patients. It's the whole why me thing, and I'm at my age, I shouldn't have it, and it's terrible. And you try to give them the reassurance that yes, we can get as much clearance as we can, and in the minimum amount of steps with a minimum amount of fuss. And he really didn't want anything else. He didn't want any bones removing. He didn't want any radiotherapy. He really, and even when we said about the globe sparing at stage 2, he just wanted rid of the tumor. He just didn't want anything more. He didn't want another week, because basically what we would do is we would excise and then wait for paraffin section confirmation on histology a week, and reconstruct or do further excision 4 or 5 days later. So you're on a sort of a conveyor belt of almost 2 to 3 weeks, cutting and cutting and cutting to make sure that you got clearance. And again, there's no guarantee that you could get clearance, particularly when it's free in the orbit. And on the first excision, we were already exposing the lateral rectus. So, you know, we would have to at least take that and then even go down onto the bone and different things. So he really didn't want that. And I suppose at the end of the day, we do have to sort of work with our patients and bring them on the journey as well through the treatment pathway.
Yeah,
Thank you. Yeah, and the patient's age, his lifestyle, and his choices would make a huge difference to what you ultimately plan to choose. I think we'll move on to the next case then, and it will be the Guy Ben Simon's group, When There's No More Eyelid.
Good afternoon or morning and evening to everyone, and thanks for the kind invitation. And I have a very rare case to present of a very aggressive BCC. This was an 81-year-old police officer, and he underwent 1 year prior to admission most micrographic surgery for left temple basal cell carcinoma. In the initial report, it was written to be completely excised, and that's not uncommon. During the last year, he underwent multiple surgery for multiple local recurrences, 10 surgeries, with the last one being temporoparietal fascial flap by the general plastic surgeon. And one day at the end of the working at the hospital, I got a phone call from general plastic surgeon and said, "Oh, I have a small consultation for you. I have a patient whom we've operated yesterday, and he doesn't have his upper eyelid." Luckily enough, they put a stitch from the lower eyelid to the brow. It didn't have the entire eyelid from the lateral canthus to the medial canthus. Only the bone was exposed, and this is the temporoparietal fascial flap. And I recall Hank Bayliss told me once, you can remove the entire lower eyelid to the patient and nothing would happen to the eye. It will be a little bit red or injected, but the eye will survive. But the eye cannot survive a single day without the upper eyelid, and this was the case. Well, I didn't know what quite to do in this case. So I consulted my mentor, and every time you want to have a good advice and a practical advice, you can just call Alan McNabb. And I'm hoping I'm not bothering you with that. Then he told me, go and do the Mustarde flap for total upper eyelid reconstruction. Basically take the lower eyelid, rotate it to the upper eyelid, and take the cheek to create the lower eyelid. Apparently I had this book at home, the original book by Mustarde, but as I buy a lot of books, but I never read them. And then I looked at the original book, and then there was this beautiful drawing of how to construct the upper eyelid. Basically what you do, you make an incision here and you make the Mustarde cheek flap. You rotate 180 degrees the lower eyelid to create the upper eyelid. And I don't think Cutler Beard would do in this case. And also the patients I have seen with Cutler bead, they all suffer from severe ocular surface disease, and they are very miserable. But this one actually seems very promising. Once you create the upper eyelid from the lower eyelid, you rotate the cheek flap and you create the lower eyelid and put a nasal mucosal and carotid flap, composite graft. And then you divide it at the second stage. This is the intraoperative cases, first the initial drawing, then the burrow triangle I take to prevent dog ear, and then to fashion the cheek flap. You have to leave a hinge of at least 4 millimeters, not to sever the blood supply of the eyelid. But you have also the entire eyelid in your hand, and this is quite scary because you don't know whether it will survive, even more so after you rotate it to the upper eyelid and you rotate the vascular supply. This is the moustache flap, and this is the eyelid still. I put an anchoring suture for the beginning of the surgery. This is the nasal septum and cartilage composite graft. It was harvested by EMT who joined me for this part of surgery. And then he made relaxing vertical incision, and this will serve as the new lower eyelid. It will be like a cardboard. It won't have any motility, but then it will protect the lower part of the eye, and that's quite important when the upper eyelid will also not have any motility. And this is placing and suturing the composite graft, and this is after suturing the lower eyelid at the upper eyelid and the moustache flap. It took us more than 4 hours to perform the surgery. And at this stage, all we have to do is to pray, because you don't know whether the upper eyelid will survive, whether the eye will survive, and what will happen to the initial tumor. And I have to mention again that I didn't see the patient prior to this procedure. This is 1 month post-op after I divided the lower eyelid, the hinge, and I was extremely happy because he has mild SPK. He could see well with the eye. He didn't have any pain or discomfort. And I was extremely happy. At the second stage, they plan to do laser therapy to remove the hair and to create some sort of eyebrow. Then I thought I was really happy and successful in this case. But a few months later, he had a severe recurrence in the supraorbital area, probably due to perineural invasion of the original tumor. And unfortunately, he was offered additional treatment. Vismodegib was not available then. In this case, I operated more than 10 years ago. He developed lung metastasis and he succumbed to his disease. So what went wrong? What went wrong, I think, that he was treated initially by the general plastic surgeon without involving the oculoplastic surgeon. And we recently, I know Ganga told not to do a literature search, but that was too late. I already done that, and I'm also from Israel. And we recently reviewed 11 patients with recurrent orbital BCC. 8 recurrences occurred in the brow area. And I believe that the brow area is even more dangerous from the medial canthal area because of direct perineural invasion. And when we dive in the literature, this is a case from the original paper of recurrences after most micrographic surgeries with good outcome. This is our case. This is another miserable case who was operated many times. And if we look at the proper treatment for BCC, we go 5 years ago, an excellent review by Dinesh Silva concluded that orbital exenteration is the treatment of choice. And when he looked at risk factor, he said that medial canthal location and perineural invasion are risk factors, but I didn't find any forehead positioning. Now, the first original report, and I'll finish shortly, the first original report about Vismodegib was by Alon Kahana in 2013. And then few reports and with bigger series actually described that Vismodegib is very effective in locally advanced periocular BCC with orbital involvement, with the last biggest report by Maya Eiger-Moskovich from Israel. Now, Alon Kahana wrote a nice editorial about our paper, and he said that definition of locally advanced BCC is difficult because even a small tumor in the orbit may be dangerous to a relatively large tumor on the cheek. So TNM may not be the perfect system to grade this BCC. The cost of the drug is quite pricey. It's $7,000 US per month. It depends on the regimen of treatment. Obviously, we don't have to treat every day. The duration of treatment is still unknown because of the side effects and when you have to stop the treatment, even if you do see a response. And we believe that now that if we do find additional molecular markers, we can actually predict which patients will benefit from this medicine and what will be the exact regimen for that. But additional studies are required, mostly prospective. So now that we do give Vismodegib to any locally advanced BCC, and we also give PD-1 inhibitors for cases of squamous cell carcinoma with orbital involvement. Thank you.
Right. Thank you very much. Any of the panel experts have any comments to make?
Guy, you mentioned that you felt that forehead and brow was a high-risk area for locally advanced or difficult to manage BCCs. We don't see many with tumours arising in that area, but I think that certainly is the case for SCC. SCC of the forehead and brow really does carry a much greater risk for perineural invasion and orbital invasion compared to other sites. And we showed that quite some years ago when we published a series of patients with perineural invasion via the orbit from SCC. But I think that's less well recognised for BCC, but I suspect you're probably right. And I think the previous case also highlights the increased risk of tumours arising in the lateral canthus. Lateral canthus, I think, is a really, very high risk area as well. Surgeons tend to be a bit reluctant to perhaps take as wide a margin as they would otherwise do.
Hello.
Alan, we can't. You're frozen, Alan, on screen. Maybe you may need to restart the Zoom link. Can Ashok,
late presentations are quite common in India, and we often need to have the reconstruction of the entire upper lid. One of the techniques that I've been using is the superficial temporal artery-based flap from the temporal side and using it for reconstruction. The reconstructed lid is very bulky. We do need a nasal mucocartilage or tarsoconjunctiva from the other side as well. And but we managed to give a good reconstruction, a reasonably mobile lid, protecting the globe rather well. The other option that we sometimes try is, of course, the midline forehead flap for those lesions which are starting from the medial canthus region. But the superficial temporal artery one, particularly with intact vascular supply, is done fairly well for us.
Thank you very much. Just one comment. For the upper lid, we tend to do lower lid rotation, and we don't do anything for covering the lower lid. It seems to stretch out very nicely, 6 weeks or so, and then undoing the flap. That's been our experience. And upper lid, we rarely use cutler beard or completely given up. We rotate lower lid into the upper lid, as described very nicely by Mastade, but we don't reconstruct the lower lid that often. I don't know what the experience is with the other expert panelists. Thank you.
Thank you. Just one comment is worth noting. As you say, it's not the size of the tumor, it's the tumor biology. And I think those that have perineural invasion are at particular risk. And in addition, the sort of so-called bassis squamous BCC, I've certainly seen 2 patients who had a small lump removed. They weren't really followed up. They were told it was a rodent ulcer, and lo and behold, they then pitched up with perineural invasion into the infraorbital nerve, tracking it straight into the brainstem. So I think it's about suspicion and about making sure they don't fall through their follow-ups. That's where the danger lies, I think.
Thank you, David. I think we'll move on to the next case now. Mritika Sen and Santosh Unawa from Center for Sight, Hyderabad. 3 men and a tumor.
Good afternoon, everyone. Is my screen visible?
Yes.
Hello, everyone. Thank you for the wonderful opportunity. I'll be telling you the story of 3 men and a tumor. We have no financial disclosures. So he was a 74-year-old gentleman with a right eye upper lid swelling since a year. He was being treated for chronic blepharitis. An incisional biopsy done elsewhere was suggestive of a sebaceous gland carcinoma, and he was referred to us. He was photophakic in both eyes, and the lymph nodes were not palpable. On examination, there was thickening of the lid margin, rounding of the posterior lid margin, and loss of meibomian gland orifices. However, the eyelashes were all intact. On everting the eyelid, the posterior extent of the tumor was much greater. It was yellowish, and it was involving the tarsus and the lateral canthus, with the surrounding conjunctiva being congested. So we did an excision biopsy with 4 mm clinically clear margin. A differential dissection of the posterior lamella was done. Intraoperative frozen section was used to ensure that the margins were negative. After performing a MAP biopsy, the eyelid was reconstructed using cutler beard procedure. On histopathology, the diagnosis was confirmed as a well-differentiated sebaceous gland carcinoma. MAP biopsy was negative. 6 months later, the patient is doing well. So, in such cases, when an elderly patient presents with chronic unilateral blepharitis, it is important to have a suspicion of malignancy. Loss of eyelashes is not present in all the cases. The signs should be taken together as a whole and not individually. The tumor usually extends beyond what is clinically evident. A good preoperative slit lamp examination with eversion of the eyelid to assess the posterior extent is very important. Differential excision can allow a relative conservation of the anterior lamella and an easier eyelid reconstruction. Moving on to our second case, this was a 63-year-old gentleman with a left eye upper lid swelling since a year. An incision and curettage was done for a suspected chalazion. However, no histopathological examination was done. Since 3 months, he had a recurrence. Again, the lymph nodes were not palpable. It was a nodular lesion with the loss of eyelashes and meibomian gland orifices. It was a relatively larger tumor with intrinsic vascularity. Palpable conjunctiva was congested and chemosed, and there was a ropey discharge. Again, we did an excision biopsy with clinically clear margins. Intraoperative frozen section showed that all the margins were negative. A MAP biopsy was used to rule out pagetoid invasion, and the eyelid reconstruction was performed. On histopathology, it was a moderately differentiated sebaceous gland carcinoma. MAP biopsy was negative, and there was no evidence of lymphovascular or perineural invasion. Sebaceous gland carcinoma is known to masquerade a number of benign features, symptoms, including chalazion, and only about 1/3 of the cases are diagnosed as sebaceous gland carcinoma at presentation. A prolonged duration of symptoms and delayed diagnosis is associated with increased morbidity and mortality. Coming to the surgical technique, if we do only wide local excision, the local recurrence rate is quite high, almost 36%. However, an intraoperative margin assessment can reduce this recurrence rate by almost 50%. This can be either with Mohs micrographic surgery or a frozen section. 6 months down the line, the patient is doing well with no local recurrence or nodal involvement or distant metastasis. To summarize, chalazion usually does not present in an older patient, and if it does, it is important to have sebaceous gland carcinoma among the differentials. All specimen must be sent for histopathological examination, and a protocol-based management with intraoperative margin control allows prevention of local recurrence. Coming to our last case, this was a 68-year-old gentleman with an upper lid mass and redness since 3 months. 2 years ago, he had lost vision in that eye following an infection. Incisional biopsy done from the upper lid skin was suggestive of Bowen's disease. When we reviewed the slide and block, it was suggestive of a sebaceous gland carcinoma with pagetoid invasion. He denied PL in that eye. The mass bled on touch, and there was diffuse involvement of the ocular surface and both the lids. A CT scan showed that there was anterior orbital extension with involvement of the insertion of the lateral rectus. Orbital extension in a case of sebaceous gland carcinoma is seen in almost 6 to 17% of the cases. Metastasis can be high, up to 25%, and mortality rate can vary from 5 to 30%. There are certain clinical and histopathological risk factors for the same. Now, for an extensive sebaceous gland carcinoma, the management options include orbital exentration, posterior lamellar resection, neoadjuvant chemotherapy, primary radiotherapy, or plaque brachytherapy. In our patient who had no vision, a thiazical eye, and extensive involvement of the ocular surface, lids, as well as orbital extension, we did a partial lid-sparing orbital exentration with frozen section margin control and a transverse blepharophy. Histopathology showed a sebaceous gland carcinoma with extensive pagetoid spread. Again, the margins were all free, and there was no lymphovascular or perineural spread. 2 years down the line, the patient is doing well with no local recurrence, nodal or distant metastasis. To conclude, Pagetoid spread is a risk factor for recurrence, lymph node involvement, distant metastasis, and mortality. In case of extensive involvement with advanced unresectable tumor, exentration may be indicated. However, the number of cases undergoing exentration has reduced in the recent years with the availability of other options. Neoadjuvant chemotherapy can significantly reduce the size of the tumor, allowing a lid-sparing exentration or a conservative surgery. Systemic evaluation in such cases is essential to rule out distant metastasis. Thank you very much.
Thank you. That was an excellent presentation outlining the spectrum of the cases that you see. I would like to hear Santosh tell us more about how he uses the mix of therapy options that he has. How often does he need to use the neoadjuvant therapy? And something more about the choices that he makes in these different cases.
If it's a localized tumor, then surgery is the treatment of choice. But surgery has to be accompanied by margin clearance, intraoperative margin clearance. And if it has a diffuse component, pagetoid component clinically, then you would definitely want to do a map biopsy as well so that you can localize the areas of pagetoid invasion and treat those areas. Otherwise, there is a chance of local tumor recurrence and recurrence of pagetoid tumor. Pagetoid variant can be treated with topical mitomycin C with limited success or with excision of the involved conjunctiva and cryotherapy. And we have a conformal plaque which looks like a symblepharon ring that can also treat pagetoid invasion. Now, use of neoadjuvant chemotherapy comes into play only when we have unresectable tumor which cannot be primarily resected, and these patients may be up for orbital exentration. In such patients, using chemotherapy can shrink the tumor to about 60, 70, 80% of its initial volume, thus make conservative surgery possible. So that's the situation when we use neoadjuvant chemotherapy. One more situation where we use neoadjuvant chemotherapy is when the patient has regional lymph node metastasis already. So that actually helps in getting a surgical clearance when they do a radical neck dissection, and that's often followed by IMRT. That's about it.
What is the role of sentinel lymph node biopsy in?
Right. Sentinel lymph node biopsy has a role for larger tumors. And current understanding is that instead of doing sentinel lymph node biopsy, even annual PET scan is as effective. But if you have sentinel lymph node biopsy available as in your setting, then definitely that has a role for larger tumors which are more than 10 millimeter in diameter.
David, your comments?
Yeah, in my experience, there can be a big difference in the phenotype between these two patients. I clearly remember one lady with a nodular sebaceous cell carcinoma, the MDT advising exenteration, which you clearly didn't need. So if you can clear it with margins, as Santosh was saying, this is a surgical treatment. Now, she was cleared with margins. She did not have exenteration. She spent the rest of her last 5 years perfectly happily. Again, now we had another patient. If you have intraepithelial spread, and Jeff and I and others are just working on a paper to show that even if there appears to be relatively little going on, but you do have positive mapping biopsies, be very careful because those cells unknown to you will have already spread into the lacrimal gland and more distally down into the nasolacrimal duct, and you won't see that as a mass effect. And so when you've got evidence for intraepithelial involvement, and I know there's a vogue now for treating these patients with mitomycin C or interferon, be very careful because I think the disease is often spread way further than you've realized. And we saw this on a number of exenterated specimens. They had been exenterated, the decision had already been made. But when we went back and looked at them, we were very surprised to see how far these atypical or neoplastic cells have spread retro and anterograde. So I think it depends on the nodularity, but just be very careful because it's surgical and it can spread far, far further than you realize at first presentation.
Santosh, if you
had a very good point. I know we are running out of time. Sachin's group tend to treat intraepithelial spread or in situ sebaceous gland carcinoma spread with mitomycin and interferon than with exenteration. Sachin, do you have a quick comment to make before we move on?
Yeah, so we have to be, so that's what Hardeep and me are working on at the moment is, again, in the pagetoid, there are two different groups, Sampath. There's one which is the pagetoid invasive, which Santosh is talking about, And clearly those, once they've invaded, you really can't have any other option rather than exenteration. But the pagetoid in non-invasive super spreading ones are actually just superficially spreading without invading into the deep layer. We probably take up to between 8 to 12 different areas mapping biopsies to really confirm that there's no deeper invasion. And those we're actually treating topically. And they do need exenteration at some point, as with time the ocular surface gets overloaded with the tumor volume and they get painful sore eyes. But this group of patients we followed up over the last 2 to 5 years, some of them, and they haven't had lymph node metastasis. So that is just demonstrated as clearly the ones that are superficial, non-invasive spreading are a different beast compared to the invasive ones. So yeah, we manage some of these without exenteration as primary treatment.
Does cryotherapy do any good to those with some pagetoid spread, maybe just a single spot or something that you get in your map biopsy?
Ashok, what we found is that cryotherapy is actually very nasty to these patients. It really causes further symblepharon. It does treat the disease, but what happens to the tumor is it completely scars the whole tissue down, and the pain and the discomfort they get after cryotherapy is becoming more and more horrendous. So we've now moved from mapping with cryo at the same time to actually maps and then topical chemotherapy with mitomycin. One thing we find is topical vitamin A, like Vitapos, seems to be, and topical steroid application seems to be helping these non-invasive ones.
Thank you.
Thank you.
We'll move on to the next talk. Next presentation is by Dimitris and Rebecca on an unwanted visitor.
Hello.
Yeah, fine. Carry on. Thank you.
My name is Dimitris Kapandais, and I'm the Oculoplastics Fellow in Bristol Eye Hospital. I would like to thank the organizing committee for giving me the opportunity to present this case of an unwelcome visitor during COVID-19. A 72-year-old male patient was referred to our clinics for a suspicious right upper lid lesion, which have been increasing in size over the past 5 weeks. He had a previous medical history of facial BCCs and a long-standing pigmented cheek lesion, which was previously biopsied, and it was non-malignant. On examination, there was a pink fleshy lesion in the lateral upper lid and lateral canthus with some telangiectatic vessels, which looked more like a pyogenic granuloma clinically, and diffuse brown pigment in the right lower lid and cheek, which seemed like lentigo maligna. We took 3 biopsies for these lesions from the areas shown here, and the histopathology report had an unwelcome finding of desmoplastic melanoma of the right upper lid, and the lower lid lesion was a lentigo maligna. So in the subsequent MDT meeting, it was decided to do a wide excision of 1 centimeter of the melanoma with margin control. It was also decided that a sentinel lymph node biopsy was not necessary, as the lesion was small and possibly desmoplastic, which tends to grow more locally compared to other melanoma subtypes. A staging MRI was clear. Regarding the lentigo maligna of the lower lid, we could just observe it, but it's noteworthy that the patient wanted it all gone. For the excision of the lentigo, we could have used the linguine margin control excision, which is an excision of a ribbon of tissue around the lentigo, then dividing it into equal parts, strips, which look like linguine pasta, and suturing the defect with a continuous suture. Then, depending on the histopathology result, further wider excision is done, or the main specimen is excised and reconstructed. We can see this technique here for a tumor in the inguinocrural area. And the main benefit of this technique is that the main specimen is left in situ instead of a big hole until we have the histopathology result. But unfortunately, afterwards, the COVID pandemic hit the UK, so all theaters were shut down and all staged excisions suspended. Also, all surgeries under general anesthetic, as all anesthetists were redeployed to ITUs. So we decided a more conservative excision of 5mm margin, so we could get rid of the malignant component and achieve a direct closure without the need of any complicated flaps and grafts, with a view to do a further excision and reconstruction when theaters would reopen. We would also decided to excise the lentigo with a 5mm margin. And we can see here in this nice drawing from Ms. Ford, the reconstruction with a direct closure of the upper lid and cheek rotation flap of the lower lid. The histopathology report confirmed the diagnosis of the dermoplastic melanoma, but unfortunately there were positive lateral and superior margins, and the lower lid was indeed a lentigo. We can see the postoperative healing, which is good. In the new virtual MDT meeting, it was advised to further excise 1 centimeter superolaterally and 5mm medially. While regarding the lentigo, it was decided to wait until it healed and then re-excise or apply imiquimod cream. In the further re-excision, luckily theaters reopened for cancer cases, so a two-stage excision was planned. With the first stage, 1 centimeter was re-excised superolaterally and 5mm medially, which got completely removed the invasive element of the tumor. There was some lentigo in the lateral margins, and it was decided to excise a few more millimeters laterally. So a new small re-excision was done, and the reconstruction was done on the same day, which we can see here. Free tarsal graft from the left upper lid was used to reconstruct the posterior lamella, while a bucket handle skin flap from the subbrow area of the right eyelid was used to reconstruct the upper lid, and upper blepharoplasty skin graft to reconstruct the subbrow donor area of the right. We can see the postoperative healing, which is good. The main learning points are the fact that the margin control is important when excising malignant skin tumors. Melanoma can be atypical and amelanotic. Desmoplastic melanoma can arise in lentigo areas, and they can usually extend far away beyond the visible clinical margins. Concluding my presentation, I would like to ask the audience if anyone has experience of extensive lentigo changes and how to treat them. Thank you.
Thank you. Can we hear the panelists on the questions raised? David?
Well, no, just to say that's a lovely presentation. And I think defining the field change and where it stops is very useful. We had a patient similarly, large lower lid, where does it stop and where does it start? But if you can define the ring or the periphery where it stops, then the impact of the patient having then requiring to lose a lot of tissue is much less, because if you take the main bulk of the tissue first, you may have that patient with a large defect for a long time until you've identified the periphery. But it is difficult and it is a field change, and I don't have any better wisdom to offer than the technique is a good one. And it was one that the Mohs dermatologists, I think, came up with, and one I first used about 5 or 6 years ago. You define the periphery first. When you're clear on that, you know the rest must be clear. But of course, they can have patchy involvement further afield. That was just an aside.
Sachin, your comments?
Yeah, so we at Sheffield, we're a National Ocular Oncology Center. We see a lot of conjunctival melanomas, and what we find is that some of these are associated with field changes onto the skin surface. So you could have a conj melanoma which is extending onto the eyelid, or you could actually have an eyelid with the possible lentigo maligna changes, which is then spread onto the conjunctiva. So a tip I would suggest is if you've got any periocular pigmentation, please consider doing mapping biopsies of the conjunctiva, as again, like the skin, you can have amelanotic changes on the conjunctiva. That's the first one. The second tip, what Hardeep and me work very closely on these, because what we want to find out is that lentigo maligna melanoma, or is it just pure lentigo maligna? Because if it's pure lentigo maligna, we simply treat with topical imiquimod and perhaps 5-FU or the skin surface, and then treat the conjunctival surface with topical chemotherapy rather than extensive excisions. But you need lots of maps, lots of, a lot of patients and a pathologist who is keen and happy to go through each biopsy with you. And we find that these work equally well as an option to radical extensive surgical excision. But yeah, obviously, if any biopsy shows underlying melanoma, then you have to go for option, the surgical option.
Can I just ask some advice? So I think the key thing that surprised me with this case is it was such a small amelanotic melanoma, and then the field change extends way out, not just into the area that actually looks pigmented, but there was actually invasive melanoma in parts of the lid that look normal. And then, presumably there's sort of diffuse field change all around. So yeah, perhaps I should do some more wide field mapping biopsies. And then I was thinking to treat with imiquimod when everything's settled down and he comes back now that lockdown's over.
Rebecca, we just have to be mindful with, Hardeep probably remembers this one case where we did an exenteration with a lid melanoma. And then I went further further up, and there were still pigment cells further out. And what Hardeep said is, these are actually not invasive melanoma cells. These are actually changes. These are cells which, melanophages or something else. So you really need to work with the pathologist. So, otherwise, where do I stop? And thankfully, she's alive for 5 years down the line without any seeding elsewhere. So there's so much more we don't know about these very rare cases. Hardeep wants to say something.
Just briefly, that around an area of in situ melanoma, you tend to also have hyperplasia of melanocytes. And the reason why conventional skin teaching says to excise a wider margin is to get rid of those hyperplastic melanocytes that can provide a nidus for future recurrences. And so the biology is that you can get hyperplasia melanocytes as there's a halo, a penumbra effect around the in situ melanoma. And so they can then turn into melanoma at later dates.
So would you treat that whole area with imiquimod, I think is the question, or just the areas where we can see? Because as you say, I have a strong suspicion that most of that side of his face may be involved in these melanocytic changes.
I personally would watch him, and if there's any other areas, then treat it that way. I mean, where do you stop? Most of these, I'll let Hardeep say something.
Just one more point, Rebecca, and that is that desmoplastic melanoma is defined as where 90% of the tumor or more is desmoplastic. And they tend to have a better prognosis with a reduced lymph node metastatic rate, higher local recurrence rate. But as soon as you have a mixed melanoma where you have desmoplasia less than 90%, then they have the prognosis of classical melanoma.
Yeah, there was certainly some debate amongst the pathology in the MDT about whether this was truly desmoplastic. Yeah.
Can I make a point here?
Thank you.
Okay, there's another variant of desmoplastic melanoma called a neurotropic variant, where the tumor invades the nerves. So these have a greater tendency to recur locally as compared to other desmoplastic melanomas. So it's very important to ask a pathologist whether there's neural involvement.
Thanks, Kaustubh.
Kaustubh, one last question to you. What would you say about the incidence in Indians vis-a-vis the Caucasians, you and Santosh? Melanoma.
Dr. Santosh, do you want to answer this?
Well, I think it's much lower compared to what we see, what is seen in the West. The incidence of eyelid melanoma is much lower, whereas we have had a spurt in ocular surface melanoma recently, either arising from a pre-existing PAM or a nevus transformation that has increased, but lid melanoma, we don't find that it's less than 10%, less than 5%.
Of all those that present to you with lid tumors, right?
Lid malignancies.
Yeah.
Sebaceous gland carcinoma is still about 6%.
We are running a little bit behind. Thank you.
Okay.
Yeah.
All right.
Okay, we move to the next one, which is by Dr. Uyet Santiago Creepy Crawlies from Philippines.
Hello, everyone. I'll proceed right away with my case. So this is a case that I saw in a provincial hospital. It's a case of a 76-year-old farmer from the rice planting regions of the Philippines who presented with severe left orbital pain. His condition actually started with a small brown lesion on the lower eyelid that progressed to ulceration and bleeding over 10 years. It was on the 8th year that I first saw him at a different clinic. There I saw an ulcerated lesion with rolled edges that has obliterated the lower eyelid margins and extended to the upper eyelid. As you see in the photos, there's also ptosis and limitation of supraduction. So apparently there was orbital involvement already by this point. So I did full thickness incisional biopsies in several sections that confirmed an eyelid carcinoma. I'll reveal that to you later. But definitive surgery was not done because he did not return. It was 2 years later when I saw him again, now at this provincial hospital, with an ulceration of the orbit and what I thought here were remnants of the globe. He lost vision in that eye a year before. There were no lymphadenopathies, but he was pale. The plan was to proceed with total exenteration after cardiopulmonary clearance. But the next time we saw him was at the emergency department where he was suffering from excruciating pain. What we saw was bleeding, and we heard squishy creeping sounds from the orbit, and the video shows you what we saw. So these are actually tiny little maggots. So now we are faced with two problems. The first is the malignancy. Based on the history, the risk factors, the initial presentation, the indolent course, and the clinical characteristics, we can consider basal cell carcinoma as the most likely diagnosis, although squamous cell carcinoma can also be suspected. And problem number two is this infestation, which is the orbital myiasis with likely bacterial infection. So in our investigations, the abnormal findings were managed accordingly by the proper subspecialty. CT scan showed here loss of orbital tissue and a surprisingly intact globe. So the management was composed of a team, but the primary goal was to first control the infestation. So wound debridement by removing the maggots was done twice a day. We gave antiparasitic cream, gave antibiotics, and managed the pain. It took, so maggot analysis revealed screwworms that come from gravid blowflies. So these find their way into open wounds because these flies are attracted to warm-blooded animals, including humans. So in the days before the infestation, the patient started to isolate himself, and he was sleeping outdoors on a hammock close to a pig and chicken farm. So livestock is one of the hosts that are known to these pests. So it took a week for us to be able to manage to clear the infestation from getting about 100 maggots per extraction to 0. And you see what we are left with is it's a clean ulceration with no more necrotic debris, but still with the intact eyeball. So I finally proceeded with total exenteration with wide margins. Fortunately, the orbital walls were intact. So I just left the wound open for secondary healing. So on histopathology, it showed two kinds of cells. So there's a central squamoid cell group and also a peripheral basaloid cell group. And this was signed out as basosquamous carcinoma, the same diagnosis I got during the first biopsy. So these are the post-op photos. The last time I saw him was after a month post-op. He did not return again, but it was healing quite nicely after a month. So basal squamous carcinoma is a rare variant of basal cell carcinoma. You cannot distinguish it clinically based on its features, but this but it's generally highly recurrent, and it has more potential for metastatic spread. So our main challenge with this patient is his tendency to ignore his condition and to neglect the problem despite adequate counseling. So there was delay in treatment. It also didn't help that he lived in isolation close to livestock. If there were silver linings, number one, he's lucky the tumor did not spread metastatically. And if anything, the maggot infestation actually cleared the necrotic tissue and left us with viable tissue, although causing severe pain and infection. So just to start the discussion, my questions for the experts are, what's your experience in managing basosquamous carcinoma? And second, maggot therapy is actually a biotherapy that's being used by introducing disinfected larvae in necrotic non-healing wounds. Has anyone here ever tried using it for large necrotic tumors? So thank you for this opportunity to present my unforgettable case. I'd also like to acknowledge my residents who bravely and diligently helped me with this case, especially in extracting these creepy crawlies. Thank you.
Thank you for the nice management of a difficult, highly unusual case. Let's hear our panelists. Alan?
Fortunately, I've only ever had to deal with maggots in a wound once in my career, and that was a very unfortunate lady who had a very advanced fungating tumor that was being managed palliatively at home by her daughter, who could not cope one day when she discovered there were maggots within the tumor, and the patient was brought in. I remember discussing this with an older surgeon who said, "Oh yeah, we'll just leave the maggots on there for as long as you like, and they'll clean up the wound nicely for you." But we couldn't do that. We just took them away. I did learn one useful
very
tip.
difficult thought.
I did learn one very useful management tip from that lady, and that was a palliative nurse, because these patients at the latter stages of their life with fungating, horrible head and neck tumors often have a revolting smell attached to them, which makes their end days even more difficult. And the palliative nurse had a useful suggestion for that, which was to place a tray of cat litter under the patient's bed, and that tends to absorb some of the smell. I've never forgotten that. It was one of those cases you just never forget. But no, I don't have any other experience apart from that one case.
You never forget a maggot case. That's true.
No.
So what is the role of ivermectin orally? How would you use it?
Oh, I mean, most of these cases, the infestation is quite superficial. You're probably better off asking a farmer.
Yeah, it's good.
A farmer who in Australia we deal a lot with lice.
Well, when the outside's cooked, and I put a bit of tomato sauce on the top.
Thanks, Tim.
And Eamon, if you can bring my champagne glass in too. Thanks.
Thank you, Tim. You know, Australian farmers have to deal with what's called fly strike, where poor old merino sheep get infested with maggots. And they have far more experience than I do with managing fly strike. But no, I don't have any experience with ivermectin.
Santosh, would you share your experience?
Ivermectin works well for, I mean, you don't have to, get into the messy kind of surgical intervention of trying to remove all these maggots, because ivermectin works very rapidly. 3 days of 100 microgram, I believe, per kg body weight is the dose. Systemic ivermectin or even topical ivermectin 0.1% is used for maggots, and it's quite helpful. You don't have to do, the messy surgery.
Yeah, thank you. I think
That's
we've
good
had some.
to know, Santosh, because this is actually my second case of maggot infestation, and both cases were basosquamous carcinoma.
Right.
I just ask, it's Cornelius here. I mean, is there a role? Well, why do you have to sort of physically extract all those maggots when you've got a fungating tumor that you're going to have to exenterate anyway? Will you not clear the maggots with the exenteration tissue?
Well, that's one option for sure.
Well, we couldn't get clearance from infectious disease to do a dirty surgery. So that was their advice. So we just followed because we asked for their help.
What happens when the maggots die? Don't they add to the necrotic tissue? Is Jeff Rose. You know, so if you poison them with ivermectin, you're left with even more dead tissue. You know, a few friendly maggots clearing up is quite useful for a while. But great case.
Yeah,
They support us, Jeff.
something, yes.
I think if there are no more comments, then we would like to just take the learning lessons from the 6 cases that we've seen, a really wide spectrum of conditions. The first few were basal cell carcinoma, and we discussed the strategies for management when the presentation is rather late, from surgical excision to radiotherapy to vismodegib. All the options have their own merits and demerits and cost factor. And of course, the factor of what the patient would choose in a particular situation, looking at the advantages, disadvantages, and the costs involved. And the case 2 involved recurrence of a basal cell carcinoma and orbital extension. And the options were very clear-cut, were all looked at, including super exenteration, including radiotherapy, and the pros and cons were discussed again. And I think the patient's choice, again, lifestyle choices, his age, would all have a bearing on what we choose in a given case. Case 3 was about major malignancy which had left the patient with no upper lid, and we looked at the options for reconstruction. We looked at how important it is to create some kind of an upper eyelid immediately, and for the ocular plastic surgeon to be involved right from the beginning so that there can be a better planning. The options of mustard flap was beautifully presented. The other options, including the midline flaps and the superficial temporal artery based flaps, and the need for reconstruction of a good inner lamina were looked at. Case 4 was, of course, the entire spectrum of sebaceous carcinomas, and we looked at the options. We looked at the spectrum of diffuse, nodular, and vegetoid spread. We looked at the possibilities of neoadjuvant therapy. We looked at the options of exenteration for those cases with extensive vegetoid spread, or other options including cryotherapy. Role of sentinel lymph node biopsy was looked at. Case 5 was the malignant melanoma from lentigo maligna, and the importance of very wide excision was stressed, and the possibility of recurrences was looked at. And the final case, of course, we just discussed the rare involvement of maggots due to poor nutritional status, neglected cases, relatively poor hygiene, and these cases have the option of the antiparasitic therapy as well as the surgical exenteration. So I think a very interesting mix of cases. Would welcome any more comments and then pass on to Dr. Raghavan for the next session.
Thank you, Dr. Grover. Gagai here. I think great stimulating cases, and in keeping with time, let's move on to the lacrimal drainage system tumors, or what look like tumors to us. My pleasure now to introduce 3 great panel of expert faculty, Dr. Tim Sullivan, who has been actually guiding us through several webinars over the past several months from Brisbane. We have Dr. Javed Ali from Hyderabad, India. I call him the world's only dacryologist. He's, apart from being several different types of professors, he's a Hong Leong professor with the National University of Singapore. And we also have Dr. Farzad Pakdel from Iran, along with whom I organized the very first oculoplasty webinar. We have a nice series of cases all the way from the Middle East, from United Arab Emirates with Habib, followed by Iran from Farzad himself and his team, then one from Singapore, and finally one from Japan, Dr. Toru Suzuki, whom I regard very highly for lacrimal drainage system obstructions. Over to you, Habib.
Hi, can you hear me?
And chairpersons here.
Hi, can you hear me?
Yes, nice and clear, no problem.
Oh, great. Okay, and can you see my screen?
Yes.
Okay, thank you very much for the opportunity. Hi, Raghavan. How everybody? Ganga, thank you very much. So I will be talking about, I work in Abu Dhabi, Sheikh Khalifa Medical City. I will be talking about a very interesting case. This is a young boy, very, very healthy, 17-month-old, who came to us in 2016. And 2 months prior to his presentation, he had a syringing and probing with silicone intubation in another healthcare facility. 1 week later, there was a right medial canthal swelling with erythema, which wasn't going away. And he was admitted to multiple hospitals, treated with multiple antibiotics, but not getting better. Then we get a phone call that, can you see this patient with dacryocystitis, preseptal cellulitis? We saw it was on a Thursday afternoon before a long holiday. So he came, we admitted the patient, and the mother brought the CD of the CT scan, but we could not open it. Patient was vitally stable, afebrile, active, eye movements, everything was normal. And apart the picture, which you can see, we took it from my mobile in the emergency room, and nothing else. Everything else was completely normal. So he was admitted under pediatric team. Antibiotics was started with the pediatric infectious disease team on this medication. And 2 days later, we didn't order this CT scan, but the pediatric team ordered a brain CT scan. And then, as you can see, there was a diagnosis of the dacryocystitis. As I said, it was a long weekend, and I went in and I saw the patient, spoke to the mother. Mother said, you know what, Habib, you have to take a biopsy. I said, why I have to take a biopsy? He said, because it's not getting better. I said, you're the only mother who is asking me to take a biopsy from his child. So anyway, the patient wasn't getting better. So a pediatric team put him in low dose of steroids. Swelling came down nicely. I palpated the area, and there was a nice subcutaneous mass there. Then MRI face, and if you can see, there is the end of the tube, of the silicone tube in his nose there. And MRI was done, and compared to the previous CT scan, there was a suspicion of the rhabdomyosarcoma. And therefore, we discussed with the parents that we need to take a biopsy. A biopsy was taken from medial canthal area, and the silicone tube was tube. It was sutures to the nose with, I think it was a 6 silk suture, and then we removed that one at the same setting as well. Histology came back to Aspergillus species. There was no evidence of malignancy there. And then pediatric infectious disease team started with systemic amphotericin B, and IV antibiotics was continued. In a couple of days, and then the following week, the condition was getting bigger, as it is, as you can see here, and this was the previous one. So we were thinking that, we had an MDT. We were thinking, is it a resistant strain, or is it really a rhabdomyosarcoma or another tumor which there was a superimposed infection. So if you see this CT scan, we did a CT scan, and you can see that it's getting bigger and bigger. The lesion infiltrating the inferior rectus, inferior oblique muscle. So, I mean, the only way we discussed was to go and do full debridement. So we went through a subciliary to the side of the nose, the incision extending up to the upper lid, because the lesion was, the mass was extending up all the way up. And then we really debrided as much as we could. And even we removed the inferior oblique muscle as well, because I was convinced it's a rhabdomyosarcoma with a superinfection. And then we closed it completely. And interestingly, we did it on a frozen section with every single piece which we were sending. We were waiting for the results, negative for malignancies for every single piece, and all reports, all pieces is for aspergillosis. A week later, also mucormycosis, mucorale was growing here as well. And remember that this was a completely healthy child. So the pediatric infectious disease team, they added voriconazole to the regimen. He was improving. The congenital immune deficiency SCID was ruled out. And a follow-up MRI was done, and he was getting much better. And here he is after his first surgery, 2017, 2018, and I saw him actually end of last year. So my question to the panel is that what we have missed at the beginning, actually I can tell you what we have missed later on as well, but could have we diagnosed this case earlier, and what would you have done else? The last question is that was the silicone tube to be blamed for this condition in this healthy patient? Couple of nice studies, one nice study from the Agraval team where they had 8 patients with excellent results. Our result was excellent, thanks to God. But if the patients have any other comorbidities, the result is disaster. Thank you very much.
Thank you, Habib. Over to you, chairpersons. Tim.
Well, thank you, Ganga, and thank you, Habib, for a very interesting case. It's quite difficult to think that we might get a fungal infection in a child of this age, but it does happen. We recently published 6 cases in JPOS in 2019, but all of those patients were immunocompromised in one way or another. Our patients had diabetic ketoacidosis, ALL, leukemia, and other blood malignancies. So we didn't have anyone who was not who was immunocompetent, and we had, I think, 3 cases of mucor. And they actually did badly in the pediatric population, like the adult population. We also had Escherichia, but we didn't have any Aspergillus. So this is a little bit unusual.
It just combined both of them, I have to say, and the kid was completely healthy. We extensively investigated the patient.
Sure. So that's what makes this unusual, and thank you for reporting this to us.
Yeah, thank you.
Javed, do you think this is a lid pathology or this is a lacrimal pathology?
Well, are you able to listen to me?
Yep.
Yeah.
Yeah. For me, the alarm bells would have ringed from the history itself, because 1 week following syringing and probing and silicone intubation, the child started developing a lesion. So that process for me, I would have been thinking right from foreign body granulomas to later on come to probably fungal granuloma. The second thing, I would have biopsied the patient much earlier. If you see the initial CT scans were still showing localized lesion in the lacrimal sac area. So I would have biopsied it much earlier. And regarding Tim's thing, well, in India, we see a lot of fungal infections in immunocompetent people. So it's that for at least for our patients here, it is not a necessary thing. In fact, nowadays, the trends are changing more towards immunocompetent people rather than immunocompromised.
Any particular reason why? Is it steroids or something beyond that?
It's
and Hardeep to follow, yeah.
Yeah. No, it's a little difficult to comment on that particular aspect. What could be the reason? But like silicone stents that Habib showed was entrapped. When we looked at 50 stents and we randomly subjected them to microbiological culture, 66% of them grew fungus, and of them 70% were Aspergillus, and the remaining were followed by Fusarium and other species. So silicone stents are known to act as nidus for the local fungus that's present, resident fungus. But I don't think that necessarily should convert into an infection per se.
Hardeep?
Just a comment if I may add just one thing for the purpose of learning and teaching, is that we should have palpated this case earlier. We should have listened to the mother because they tell the truth. And we were lucky that, steroid was started, palpated the patient and saw and palpated the mass. and the parents were very, very, very cooperative, and I think that helped us a lot. Another thing which we shouldn't have missed is that the patient was well, and that goes against, you know, dacryocystitis and orbital cellulitis, or even preseptal cellulitis. There was, you know, he was playing and joyful and everything. So this case was presented as an M&M in the department as well.
Go ahead, please. Yeah, Hardeep.
So just a quick thing about the histopathology. Aspergillus branches less than 90 degrees, the hyphae, whereas mucormycosis branches at 90 degrees and has a crushed ribbon effect. So one has to be very vigilant in terms of trying to spot a more aggressive fungus on a biopsy. If you have 90-degree branching, that is not Aspergillus, it's going to be mucormycosis. Less than 90 degrees, it's usually Aspergillus.
Thank you.
So I just want to ask you one thing, like when Habib was showing the pathology, we don't have the slides, but the pathology was, I remember some slide mentioning it as necrotizing granuloma. So how often do you find necrotizing granuloma in a necrosis in a fungal granuloma?
It's very common to find necrosis because the fungi are tissue destructive and they release enzymes and various other things to destroy the tissue. You also get granulomas as well. You can get a necrotic center with a ring granuloma and the fungi in the center of the necrosis. They can also be angioinvasive, invade vessels as well, which we all come across quite often in aggressive cases like this. It's quite common, yes.
Let's get this slide.
I think as it gets a little chronic, it tends to get a little more fibrotic.
Thank you. In the interest of time, we'll move on. It's my distinct honor now to invite Dr. Toru Suzuki from Fukuoka. Those of you embarking on a career in dacryology, you should really visit his practice and you'll learn several new things about dacryology. Toru, are you able to share your presentation?
Okay. Can you hear me?
Yes, but we need your presentation.
Okay. Do you see my slide?
Yes.
Okay.
Thank you.
Okay. Thank you, Ganga, for giving me this such kind of beautiful title. This title means some tearing is standard, right? And I have 4 cases of standard due to malignant lymphoma. Interestingly, all of them are young male patients under 50 years old. I'm going to talk about this today. Generally speaking, nasal lacrimal duct obstruction is a common disease in our lacrimal surgery field, including congenital and acquired. In the acquired one, the obstruction can be secondarily caused by tumors, such as malignant lymphoma. That's challenging to an ophthalmologist like me. Its incidence is rare. It slips into a common disease. These factors easily lead us to misdiagnosis. First of all, let me start with my misdiagnosis experience in my clinic. The first patient with standard due to malignant lymphoma came to see me 2016. My initial diagnosis was left side dacryocystitis. Actually, I'm a doctor in a private clinic, so I don't have multi-slice CT. However, I have cone beam CT. In 2015, I introduced cone beam CT in my clinic, so I can perform CT examination for him. This is the CT of the case. As you can see, there is something large inside the lacrimal sac. So I thought it was going to be a huge lacrimal sac stone. I decided to perform DCR. Pre-op, starting off, ending off. This is rhinoscopy 4 years after the operation, which tells us that my operation technique was not a problem, was successful. Because there is no fibrosis, we can see the large rhinoscopy. However, intra-op or post-op findings were quite unusual to me. First of all, after opening the lacrimal sac, I didn't see any sign of lacrimal sac stone. which was not consistent with this preoperative CT. In addition, his swollen lower eyelid didn't show any improvement. It was so mysterious to me. That's why I referred this patient to a specialist. And the case turned out to be a malignant lymphoma. Looking back at this CT, I wasn't aware of, back then I wasn't aware of that there was an unusual CT finding. In the right side, we can see lacrimal bone here. Here we can see lacrimal bone. However, in the left side, there is no lacrimal bone. That can't be happening in the common dacryocyst cystitis. So I should have noticed that this was not common dacryocystitis, but I didn't. I was not good at evaluating the CT image back then. So I noticed performing CT is quite easy and simple. However, evaluating CT image requires skill. The second patient with malignant lymphoma came to see me 2 years after the first patient. By that time, I was better at CT evaluation. So this time I was successful for avoiding a misdiagnosis of this patient with right side dacryocystitis. In addition to enlarged nasolacrimal canal, I can see bone destruction here and there. So immediately after performing this CT, I could refer this patient to expert. So this is my learning points. Routine CT examination is quite important, not only for screening disease, but also training skills of the CT evaluation. So in this nice opportunity, actually, I have a question to experts. Recently, I'm having 2 more patients with SANDO due to malignant lymphoma. After chemotherapy, general hospital doctor team, including general ophthalmologist and the ENT, referred them to me asking for DCR. But I didn't perform DCR because both my patient and myself concerned about possible tumor recurrence or metastasis. Number 3 patient came to see me several years after chemotherapy. What I can tell you in this CT is he's having right side dacryocystitis, and the tumor maybe existed around this area. And the last patient, case number 4, this is my last patient in my talk. He came to see me immediately after completing a chemotherapy. Actually, this patient was having acute dacryocystitis during chemotherapy. So the doctor referred this patient immediately after completing chemotherapy. But to my eyes, the tumor still exists here. So it's very scary. I don't want to touch this. So my question is like this. Is there any risk of recurrence or metastasis due to DCR for the SANDO due to malignant lymphoma after chemotherapy? Or if performing the DCR, when is the best timing to do? Thank you very much.
Thank you, Dr. Suzuki. Can I invite 2 quick comments from Dr. Javed and Dr. Farzad regarding these 2 questions and the cases?
Yeah, two things. If you look at the major review we published last year on lymphoproliferative lesions of the lacrimal drainage system, interestingly, DLBCL constituted 43% of the 102 cases that we reviewed. So unlike other areas, DLBCL is the commonest malignant lacrimal sac tumor that's in the literature. That's one thing. Second thing is, very interestingly, that if you are looking at primary malignancies of the lacrimal epithelial malignancies or any other malignancies, the incidence of acute dacryocystitis cystitis is somewhere around 10%, which is almost on par with how acute dacryocystitis cystitis would present in a case of a pando. But that is not true for lymphoproliferative lesions of the lacrimal drainage system, where it is 31% of the 102 cases, 31% had this one. So it's not unusual even during chemotherapy, because unless the chemotherapy takes its effect, you can always expect an acute dacryocystitis. So it's not surprising, the presentations.
Thank you. Thank you. Farzad, when do you do a CT DCG for a patient with dacryocystitis? Farzad?
Yeah.
Okay.
Yeah.
Okay.
Thank you.
Yes.
So in the case of the acute infection, we usually do not do DCG for a patient, but as the case that Torup just presented to us in those patients with chronic dacryocystitis that we are suspicious to a mass in the lacrimal sac, it's a good idea to have a CT DCG to well define the tumor and the thickness of the lacrimal sac. So I would like also to mention that the most common lymphoma affecting the lacrimal sac are DLBC and maltoma. And among those, if you are in stage 1, you can treat both of them with local radiotherapy. But for DLBC, I think it's a good idea to start chemotherapy for all of these patients, as it has a high recurrence and high involvement if you just fail to cover the malignant cells in the body. So if I have time, I would like to make comments for the previous case, Ganga. Hello, Ganga.
Ganga, are you? Ganga?
Can I make comments for Dr. Habib's case? Just few quick
Very
comments.
quickly, yeah. Thank you. We are running a little bit behind schedule. Yeah.
Yeah, thank you. It was a very good case, actually, but I would like to mention that apparently based on the pathologic, it was invasive fungal infection. And I doubt that it was a congenital nasolacrimal duct obstruction or it was acquired. In the case that acquired nasolacrimal duct obstruction, actually looking at the nasal cavity and sinuses, especially with endoscopic examination, is a must, because some of these fungal infections may be actually present in the nasal or sinus cavity, even though this was a small child. But we should think about the lateral nasal wall involvement by the invasive fungal infection. So I think MRI and nasal endoscopy are must to perform in such cases as early as possible. About the treatment, I would like to mention that as amphotericin B has high actually adverse drug-related events, nowadays many experts prefer to use voriconazole for invasive aspergillosis to decrease both the side effects, and they have shown that it has comparable efficacy in those with aspergillosis. And also, I would like to say that some of the cases with aspergillosis inside the lacrimal sac, some of those are associated with foreign bodies, as Javed beautifully mentioned, that the silicone tube may act like an nidus, and other things is the presence of the dacryoleads. It's very important to note that if you have nidus inside, whatever antibiotics you do, whatever you do, if you do not remove the source of the infection, you cannot actually proceed for resolution of infection. Thank you.
Thank you. Thank you. Yeah, good points. But he was checked from an ENT, checked the patient, and we gave steroids. That's why the redness and swelling came down. And to be honest with you, we did not go at all into the sac. So the sac was intact at the end of the day.
Thank you. Can we move on to Ganga's team's case? Ganga, are you online? Okay, Tim, can you take over, please?
Yes, I think we now have Dr. Kansakar presenting the case of chemoreduction in lacrimal sac carcinoma. So this is in fact Ganga's case. So he may have dropped out for a little bit of time, but we'll ask Dr. Kansakar to present the case. Thank you very much.
Thank you, Dr. Tim. Am I audible?
Yeah,
yes.
Can people mute please the panelists other than the speaker? Thank you. Yeah, we can hear you nice and clear. Thank you.
Okay. Namaste, everybody. My name is Dr. Prerna, and I'm from Nepal. And I'll be talking about a case of lacrimal sac carcinoma in which chemoreduction was done. And this was a case we saw at NUH in Singapore. So this is a 62-year-old Southeast Asian male who was referred to us for a left orbital exenteration from overseas. The case history was that he had persisting tearing from the left eye for the past 2 months associated with pain and swelling. However, there was no discharge. So a CT scan was advised and the finding was a left sinonasal mass for which he was referred to ENT for transnasal biopsy, as well as to radiation oncology, who advised him of palliative chemo and radiotherapy. So a week before he presented to us at NUH, he had commenced induction chemotherapy with docetaxel, cisplatin, and 5-FU. In the past medical history, he was hypertensive, hyperlipidemia with hepatitis B, but no known malignancies. And personal history, he was a previous smoker of about 10 pack years. So on ophthalmic examination, the globes looked normal on both sides. He was orthophoric with full ocular motility. However, there was non-axial displacement superolaterally. On Adnexal exam of the left side, there was a firm, incompressible, immobile mass measuring about 35 by 20 millimeters above the medial canthal tendon, abutting and displacing the globe superolaterally. It was involving the margins of the lower lid, the inferior punctum, as well as the lower canaliculus. However, we could see a normal superior punctum. The regional examination, however, did not reveal any preauricular or submandibular lymphadenopathy. So we did an office nasal endoscopy, which revealed the right side was normal with a septal deviation. The left side showed a crowdy nasal cavity with fullness of the lateral nasal wall involving the middle as well as the inferior turbinate. So the close summary for this case, the clinical process was an infiltrative lesion in the left medial canthal area, possibly from the lacrimal sac area, with a subacute onset, signs and symptoms presenting with tearing and an enlarging mass in a Southeast Asian Chinese elderly male. So our working diagnosis was a left primary lacrimal sac carcinoma versus an eyelid carcinoma with secondary involvement of the lacrimal sac. So this is the CT scan that the patient had brought in with him. So as evident in the scan, we can see that there is a heterogeneously enhancing mass which appears to be arising from the lacrimal sac or possibly the nasolacrimal duct area, spreading all over the maxillary sinus. And we can also appreciate the erosion of the medial orbital wall in the CT. So we ordered an MR, and the MR delineates the mass more clearly. So we can see that the mass is extending anteriorly up to the skin and again, filling multiloculated mass, filling the maxillary sinus, as well as invasion into the left frontal sinus. So at this point, our treatment plan was to confirm the pathology by doing a repeat nasal biopsy and a systemic review by doing a PET scan or a CT, which at that point did not show any systemic abnormalities, and a multi-modality, multidisciplinary approach along with our ENT, the plastics, the neurosurgeons, and the medical and radiation onco team. And we planned for local versus an extensive craniofacial resection with possible orbital exenteration and cribriform resection with pericranial flap, left neck dissection, and a flap reconstruction, along with adjuvant, radiation, and chemotherapy. So the nasal biopsy was taken from the sphenoethmoid recess, and it revealed some atypical epithelium with enlarged irregular hyperchromatic nuclei, prominent nucleoli, and some atypical squamous epithelium. We could also appreciate some keratin pearls and atypical squamous epithelium with smudgy chromatin, which showed likely treatment-related changes. So our diagnosis at this point was a left lacrimal sac squamous cell carcinoma with a frontal and maxillary sinus mucocele with no regional or distant metastasis. So my questions to the experts are, what are our treatment options in a case like this? Should we go for a local excision versus a craniofacial resection? The role of chemo, radiation, and is orbital exenteration indicated at this point? Now, so what?
Carry on with your presentation.
Okay, so so the patient came to us after 2.5 weeks of chemotherapy, and this is our patient post the first cycle, and this is him after the second cycle. And if we remember, if you recall, this is him at presentation. So we repeated the MR scan, and this is him before the chemo reduction, and this is him after the chemo reduction, in which we can appreciate that there's significant reduction in the extent of this tumor that was previously present, and we can now appreciate a large anterior ethmoidal cell. So after this, we planned for an operation, and we did a wide excision 5 mm margins with left maxillectomy and left orbitectomy under frozen section control. There was left complete sinus exenteration with drilling of the skull base with reconstruction of the orbit with alloplastic implants, telecanthus correction with intercanthal wiring, reconstruction of the left maxillectomy defect, and reconstruction with pericranial flap, left cheek advancement, and mitter skin flap. So these are our intraoperative images. So you can appreciate that this is the mass that was removed and the orbital reconstruction that was done. We reconstructed the medial wall as well as the floor with the help of a titanium mesh implant. And histology from this specimen reveals severely inflamed polypoidal sinonasal type mucosa with prominent edema and focal granulation tissue formation, stromal fragments with pore fibrosis and hyalinization. However, no malignant tumor was identified from this specimen. So following this, we advised the patient to complete 3 more cycles of adjuvant chemo, and also advised him a post-op radiation with serial follow-ups in the form of clinical exam and imaging. And the patient was apparently well for the next 6 months. The 6 months follow-up, he presented to us with weight loss, decreased appetite, abdominal bloating, and greenish vomiting. However, at this point, he had no recurrence in the eye. There were no positive findings in the eyes. He was diagnosed as malignant ascites, and a PET CT revealed extensive omental caking and peritoneal nodularity, probably from a primary neoplasm along the pancreatic tail. The peritoneal drainage and fluid cytology reveals a pancreatic adenocarcinoma with elevated CA19-9 levels. So the final diagnosis made at this point was malignant ascites from newly diagnosed pancreatic adeno-CA, which was complicated by intestinal obstruction, and it was managed conservatively. Unfortunately, the patient succumbed to the illness in about 2 weeks. So my points for discussion in this case: what are the absolute versus relative indications for orbital exenteration, and the role of chemoreduction in head and neck tumors? Also, what is the pathological complete response for head and neck or orbital neoplasms? And lastly, reconstruction of orbits following extensive tumor resections. What can we do to avoid residual morbidity? Thank you.
Thank you. Over to you, Tim.
Well, I think this is a very difficult case, and it highlights the complexity of when one has to make that decision about, do you take the eye, do you exenterate the orbit, or do you try and preserve it? And we've seen a big change in the management of lacrimal gland carcinomas, where there is more of a trend towards globe preservation. Lacrimal sac carcinomas, particularly squamous cell carcinomas, are very aggressive, have a high rate of local recurrence, have a high rate of metastatic spread to the parotid and draining nodes. And we actually have a fairly low threshold for exenteration if we're having difficulty getting tumor clearance. If the tumor is confined to the sac and you can excise it and have a clear margin of tissue between the excised specimen and the globe, that's reasonable. But if the tumor is invading the orbit and abutting the globe, then I think we're probably obliged to exenterate in that situation. That then leads to the question of what's the role of chemoreduction, and might the patient benefit from a targeted therapy such as cemiplimab, which is very useful in cutaneous SCC, but its role in lacrimal sac SCC is unclear at this stage. So I'd certainly be interested in hearing some of the other panelists and other experts' comments, particularly Jeff Rose, who has a very broad experience in this area.
If he's not there, can I have the pathologist to comment upon the concept of pathologic complete regression? How often do they see it following chemoreduction? Hardeep or Kaustubh or Derek?
Can I make comments on that?
Okay.
Actually,
just 1 minute.
Yeah, pathologic complete regression, it can improve the local regional control of the disease or maybe survival in these patients and patients with head and neck SCC. I'm not sure if we can apply it to lacrimal sac SCC, but what we can translate that, results from the head and neck SCC to your case as well. And about NCT, the neoadjuvant therapy before doing a wide surgical, it's always good to decrease the stage of the disease to make it actually surgically resectable and resected. But we have compelling evidence. We have controversial issues about that, and many of the articles have shown that although you can decrease the stage, you cannot increase the survival of these patients. So we are not sure that the neoadjuvant therapy in these cases with the high stage of the SCC or the invasive epidermal epithelial tumors can increase the survival in these patients or not.
Just coming back on Tim, we've seen a number of lacrimal sac carcinomas, typically squamous carcinoma, as well as lymphomas involving the sac. Tim, we tend to find that actual intact resection with radiotherapy does rather well for the squamous carcinomas, but it may just be that we're seeing them earlier than many of the cases, like the one described here, involving the skull base. We may be just seeing them earlier, and that's why they're doing better.
Yeah, we've had a number where they're relatively small, contained within the sac, and they do very well with local resection and post-operative radiotherapy, as you said.
Absolutely.
But we've had, to counter that, we've had a couple where they've been more extensive and the tumour has spread along the cribriform plate and actually over towards the contralateral side, and the patient has needed an extensive cranioorbital resection, and they're much more difficult to deal with.
Agreed. Yeah, absolutely. Yeah, I've had one case that did the similar thing.
Yeah, so I would agree with Jeff because, if you look at the squamous cell carcinomas per se of the lacrimal sac, till last year, there were 241 cases reported in the literature, of which 165 had the details of their management. And if you look at that, the best outcomes were those which had initial surgery followed by radiotherapy rather than, the other concept. So I agree with Jeff, probably that's what is needed in most of these cases. And probably neoadjuvant is something that we need to go a little slower on to evaluate whether it's really useful.
One other comment.
Move on to the next case. Yeah, sorry.
Oh, sorry.
Go ahead,
I'll just make a brief comment. The follow-up is very important because we've reported our series of lacrimal sac carcinomas and the survival was actually not too bad. But over the many years that have followed, we have seen patients later develop metastasis many years down the track. So that the long-term survival actually ends up being a bit lower.
I have a point to make. This patient had metastasis despite local tumor control. That means that
this was not a metastatic case, Santosh. The primary in the lacrimal sac was a squamous cell carcinoma. But he developed a second primary, which was a pancreatic adenocarcinoma.
Okay, that was the second primary.
It was the second primary, and he succumbed to the disease very fast. Primary disease was completely in remission.
A brief comment, if I may. So quite a large number of SCCs of the lacrimal sac are driven by human papillomavirus type 16/18 high-risk types. That's first thing. Secondly, in this particular case, it may be worth looking for Muir-Torre syndrome, where you have two tumors that are related, one superficial near the skin, you could say, one visceral. So perhaps immunohistochemistry for mismatch repair proteins of the squamous carcinoma might reveal a mismatch repair in this particular case.
Just one comment to make. We published a series of our exentration. Surprisingly, we found a significant number of patients with second primary in our series, which I think ours was the first one to pick that up. A few years ago, we published in the Orbit Journal. Exentration with a second primary tumor. Maybe this patient fits into that.
Thank you. In the interest of time, we'll move on. I think I'm going to hand over to Dr. Farzad Patel and his team from Iran to talk about the last lacrimal case.
Yeah, thank you. I would like to invite my resident, Dr. Abbas Mohammadi, to start the presentation.
Hi, everyone. Nice to meet you, Dr. Ganga again.
Good to see you again.
Okay, thank you. Here is, okay. Okay, do you see my screen?
Yeah, you may go ahead,
Oh, okay,
Abbas.
okay. Okay, today we talk about a case of post-operative surprise in LS surgery. What had happened? I cannot, okay. A 15 years old male referred for recurrence of epiphora and eyelid swelling after the past discharge 9 months ago. The past medical history negative, ocular history just a NLDO in right eye, no smoker. He just history of epiphora, discharge, medical control, swelling and redness 9 months before he underwent the DCR. Of course, he reported the episode of myelodystoxis in the last few week period to refer. 5 days prior to admission, he had received topical ciprofloxacin by other colleague for eye infection. So in here you can see the medial contour bulging and the lower lid swelling. So we did spiral CT. You can see here images show the mass in infranasal part of the orbit, then extending to the apex and the intraconal cavity, and then in intranasal cavity and the ipsilateral paranasal bone destruction. So in the first admission, we did the tumor biopsy. You can hear the prominent in the pathology, prominent growth of round epithelial mass that is inverted papilloma with a bland looking. So the pathology report was inverted papilloma. So, and according to involvement orbit, the disease stage was 4 for inverted papilloma. So we recommended the parent for radical exentration, but the parent rejected any radical surgery and radical exentration. So we decided to do the chemo reduction, and after then we do endonasal tumor resection and subtotal maxillectomy. But the tumor did not show the shrinkage. And after the 2 months to start the chemotherapy, the patient came with developed acute inflammation and lacrimal abscess. After the lacrimal abscess drainage and received the antibiotic, we had the patient that chemo reduction, the failed chemo reduction. So we send the patient underwent the maxillectomy and tumor resection. So tissue sample of maxillectomy show the atypic cell with a polymorphic cell, and here the IHC for proliferative marker be positive. So the second pathology report was the sinonasal squamous cell carcinoma with extensive bone invasion. Again, we recommended the radical surgery for the patient, but the parent did not agree for radical surgery and frequently guarded against this issue. So we considered an alternative treatment plan and adjuvant EBRT. So, but the tumor showed any response and no revision of tumor. So after counseling with a radio-oncologist, we started the second chemotherapy, but the patient showed no response. So again, after another counseling, they start another EPRT and the serial course chemotherapy, but no response. Of course, after the Cetuximab cisplatin 5-FU regimen slowed down the progression. And 1 year later, the tumor recurrence by dysphagia, bilateral severe proptosis, aggravation of proptosis for last months, and the visual acuity in the left eye was decreased, the 2 meters a count finger. The patient had a left corneal scar and respiratory distress. So we did the MRI that show the invasion to the left orbit. Here you can see an involvement of the dura and the PPF. So we had the patient with a wide non-responsive tumor that had a bilateral proptosis, skull base involvement, nasopharyngeal obstruction. So better question, any further hope? So after we consulting with another colleague, we started the cetuximab, but unfortunately could not slow down the growth. So we had to do the palliative orbitotomy and tumor debulking for the patient. So after the palliative orbitotomy and tumor debulking, the wound bleeding was be controlled, and left corneal ulcer was improved, and visual acuity improved, of course. So here you can see the tissue sample of palliative. You can here see, in compared to previous sample, the IHC for proliferative is more higher. Is better to say, as the patient clinically stage progress, the pathologically of the tumor was also higher. So for preserving left eye vision, and of course the large hanging necrotic and bleeding tumor, we start the pembrolizumab. Of course, is off-label, but 3 months later, no further external growth of tumor. However, the patient developed respiratory distress and passed away. So, question to panel: any definitive measure for diagnosis of malignant transformation in inverted papilloma? And do you recommend radical or mutilating surgery in pre-malignant phase? And how do you manage in the case that a patient refuses radical surgery and exenteration? Thank you for your attention.
Thank you. Over to you, Javed and Tim.
Yeah, so, inverted papillomas, if you look at certain series, the one larger series that I remember was 12 cases of inverted papilloma, of which 7 progressed to, frank carcinomas. But all said and done, I would also like Hardeep to comment on it later on, where, whenever we have a diagnosis of inverted papilloma, we need to really scan the tissues very well, because there could be focus of coexisting carcinoma in situ. There could be de novo carcinomas sometimes later on. So it's very important to probably, scan that one. And to the first question, whether there are indicators for malignant transformation, other than the clinical for me, as your case has demonstrated, clinical indicators are probably, along with the radiological features, are probably the best ones. But it would be very good if you can go back and have a look at those inverted papillomas and look for overexpression of P53 or epidermal growth factors or transforming growth factors. And as Hardeep said, HPV 18 and 11 profiles, that would give histopathological indications whether that would transform into a squamous cell carcinoma.
So the key thing here is inverted papillomas have very well-defined lobules that are pushing into the stroma histopathologically. The cells are bland. That's the key thing. Now, in order to spot malignant transformation, as Javed said, the cells have to become cytologically atypical, so nucleus get darker and larger with a high nucleus cytoplasmic ratio, and there's an anarchic growth pattern with mitotic activity. Then the question is it in situ? Is it invading into the stroma as it breaches the basement membrane? So again, with in situ disease in inverted papilloma, again, it's well defined, like an old inverted papilloma, but as soon as you get breach of the basement membrane, then you get invasion into the stroma. And what tends to happen there is you get abrupt keratinization. The cells become larger, more eosinophilic and more keratinized, and then they invade into the stroma. So those are the ways you can tell what is an inverted papilloma, in situ inverted papilloma, in situ carcinoma, and invasive squamous carcinoma arising from an inverted papilloma.
I think that that's a very good point, Hardeep. It's interesting that if you take a biopsy from one of these lesions, that's one part of a much larger pathology. And you probably need to look at the whole specimen very closely to know that there is not a carcinoma present. So we would recommend an excisional procedure to remove the entire inverted papilloma to allow complete pathological examination.
You're absolutely right. And we know that inverted papillomas have a far higher rate of malignant transformation compared to exophytic papillomas. So there is always a suspicion in your head that once the biopsy is benign, could there be a lurking SCC in the background that hasn't been biopsied? I think you're absolutely right there.
And the other thing is that you ask about how do you deal with the patient who refers what you call mutilating surgery? Well, in fact, what we're trying to do, our obligation is to firstly save the patient's life. And then we might want to save their eye, and then we might want to save their sight in that order. And Javed has spoken very nicely about what's in the literature. I think we can tell the patients that from our experience and what's in the literature, that if these aggressive tumours are not managed aggressively, that the outcome will not be good.
And I invite one comment from Dr. Veena Norana on the radiology before Dr. Tim Sullivan summarizes the session, please.
Yeah, can you hear me?
Go ahead.
Yeah, so the initial CT itself was suggestive of a very aggressive lesion. There was a lot of bone changes, sclerosis, and the lesion was outside the confines of the sinuses. So I think at that point of time itself, I don't agree with the diagnosis of an inverted papilloma. Then the subsequent, I don't know, the pathologist is here, so probably they can comment. And then having this bilateral disease, I think the path needs to be reviewed. And plus non-responsive to therapy.
Thank you. Tim, would you like to summarize the session, please?
Well, I think it's been a very useful session looking at a number of different entities that can involve the nasolacrimal drainage apparatus that are secondary processes, whether they're infective or malignant. As we've just seen from this discussion now, the management really needs to be multidisciplinary in terms of involving our ENT and general plastic surgical and neurosurgical colleagues when appropriate, but also it highlights the importance of having very good radiological input, very good pathology input, and the ability for us as clinicians to liaise with the radiologist and the pathologist to achieve the best outcome. We saw 4 good cases, the one of the fungal infection, the aspergillus, and lymphoid involvement, our various lacrimal sac carcinomas, the SCC, and then finally the inverted papilloma that became malignant. So I think it highlights the importance of being aware of the possibility of malignancy in any patient who presents with a PIFRA. So the most straightforward patient could have a malignancy, and you just always need to have that in the back of your mind. So thank you very much.
Thank you, Tim. Can I make a quick comment, Ganga?
Yeah, go ahead, please, as Senthil takes over after this, yeah.
Yeah,
yes.
Actually, this case showed to be very wild and not responsive to ordinary treatments, medical or, radiotherapy. So at the time, we thought to use pembrolizumab for this case, Keytruda, and we found that it could stop progression of disease, although the patient died from other reasons. So I would like to say that now Keytruda has received FDA approval for actually resistant and recurrent head and neck SCC. So now we can assume that this can be started as the second or third line of therapy for these cases that do not respond to other measures. Thank you.
Well, thank you, Dr. Fazad. So now we'll move on to the next session, which is going to be on orbit.
And I would like to invite Professor Jeff Rose from Moorfields Eye Hospital, Dr. Veena Narona, Senior Consultant Radiologist from Chennai, Professor Usha Kim, who is the current president of the Oculoplastic Association of India, and Dr. Hunter Yuen from Hong Kong. Over to you, Jeff.
Thank you very much, Senthil. And I'd like to call on Fashita to talk about Born This Way, if she would. And it's one of my lenses.
Thank you. Am I audible?
You are. Thank you very much.
Start your screen share.
Is
That's
my
looking good.
screen visible?
Yep.
A newborn baby brings new hope, new possibilities, happiness, and warmth to parents. But a baby born with any anomaly can cause worry to anxious parents. Hello, everyone. I'll be presenting a challenging case of a baby born with a proptotic eye. A 6-month-old baby girl from Sudan was brought by parents with complaints of bulging of the right eye since birth. The antenatal, birth, and the postnatal period were uneventful. On examination, the right eye was proptotic with supraronasal displacement. There was a large cystic mass which was compressible, non-reducible, and non-pulsatile. There was medial and lateral canthal dystopia with an increase in horizontal palpebral fissure. The anterior segment examination was grossly within normal limits. A congenital proptosis or neonatal proptosis presents as a challenge to the clinician. The differentials can be broadly benign or malignant. Benign lesions may either be cystic or vascular. So the computed tomography imaging in a patient showed a large heterogeneous mass in the right orbit pushing the globe anteriorly and nasally. The lesion occupied the intraconal as well as the extraconal space and extend up to the apex. There was bony remodeling of the roof, the lateral wall, and the floor. It was multiloculated, hyperintense on T2, and non-contrast enhancing. There was no communication with either the globe, the cranial cavity, or the meninges. An aspiration cytology was performed at a neurosurgery center elsewhere, which revealed a straw-colored aspirate. However, there was rapid recollection of fluid. So based on the imaging, vascular lesions were ruled out as the lesion was non-enhancing on contrast. There was no communication with meninges or brain, so a meningocele or an encephalocele was ruled out, narrowing down our differentials to a dermoid cyst, an epidermoid cyst, a teratoma, or an orbitopalpebral cyst. We proceeded with a right orbitotomy with excision biopsy via an inferior transconjunctival and lateral canthotomy approach. Intraoperatively, a bilobed cyst was noted, which was excised in toto, and a small residual suspicious cyst was also noted, which was excised. Grossly, the specimen had glistening external surface. The cut section was multiloculated, cystic with smooth walls, and there were solid areas which were gray-white in color. This is a 2x magnified photomicrograph with H&E staining showing papillary areas as well as band-like areas. On further magnification of the papillary component, a single layer of cuboidal to columnar cells were noted arranged around a fibrovascular core with branching pattern. It was positive for cytokeratin and focally positive for GFAP, indicating choroid plexus. The band-like area on higher magnification showed a fibrillary background with glial cells having round vesicular nuclei with long cytoplasmic processes, which was positive for GFAP. This indicates the neural tissue. There were also areas of mesenchymal tissues where spindle to stellate cells with clear spaces in the cytoplasm indicative of lipopatous component were noted. So embryologically, there are 3 germ layers from which all the other tissues are derived. The ectoderm gives rise to stratified squamous epithelium and appendages, neuroectoderm to glial tissues and choroid plexus. The fat, bone, cartilage, and muscle arise from the mesoderm. And the endoderm gives rise to respiratory or gastrointestinal epithelium. Now, based on the number of germ layers involved, Such lesions may either be a dermoid, where histopathology usually shows ectoderm and appendages, an epidermoid cyst, or a teratoma, wherein 2 or more germ layers are involved. So in our case, there were tissues derived from the neuroectoderm and the mesoderm, the final diagnosis of a case being a benign teratoma of the right orbit. After orbitotomy and squint correction, the baby is doing well and undergoing amblyopia therapy. So I request our esteemed panelists to share their experience with similar cases and their surgical choice, and a special request to Dr. Veena Norona to share to throw some light on any role of fetal ultrasound or MRI. Thank you.
Thank you. Thank you very much. Fascinating case. As you say, it always worries parents when the child isn't perfect. And the obviously worry with any mass is whether you have an underlying more aggressive tumor rather than developmental anomaly, but you so nicely showed the various anomalies associated with development. It sort of covers the spectrum, as you say, teratoma and ectopic brain and the other things coming from above. And so fascinating, the pathology was excellent. With regard to ultrasound, you can actually identify some of these. And many years ago, we wrote up a case where ectopic brain in the lower lid, in this case, was identified on prenatal ultrasound. And so, it is useful to actually look at what's going on. So, but a fascinating case. And I think, very useful from that point of view. Yeah, they're very rare though. Ectopic brain is very rare and developmentally in the orbit. But thanks, and very well managed. Couldn't really improve on that.
Thank you, Dr.
I don't think any questions. Nobody's come up with a question that I can see.
I have a question.
Oh, Hardy.
Hi. So the pathology is much more in line with a cystic ectopic brain, and I'm struggling to see the adipocytes in that tissue. There may be vacuolated astrocytes you're seeing there. I've seen a case of cystic ectopic brain. Usually you get little microcalcifications in that type of scenario. And you can also get gliomas arising from ectopic brain tissue in the pediatric populations. We've written up a case on this as well. So I think it's much more akin to cystic ectopic brain rather than a teratoma.
That's interesting because in the case we wrote up with the prenatal diagnosis, again, you could identify neurons, yes, astroglia and calcium flecks.
Yeah, exactly. The flecks are quite important. And also, if you do a neuron stain, I'm sure this case will have neurofilament in it as well.
But it's particularly interesting with the choroid plexus when it pitches up. But I think we'll carry on at that point because fascinating.
Jeff, I have another question. Actually, hello. If the lesion was actually picked up on the first day of birth, so would you advise operating? Right away, or how long would you wait? If you want to wait until the baby is a little bit older?
Yeah, I think the very fact that it's there to start with and it looks such a benign looking lesion with a very high T2 implies that there's a lot of proteinaceous fluid within the cyst rather than a solid tumor. And, rhabdo and things like that are so rare to actually present that early and without progression that I'd bide time, but bearing in mind that you don't want the orbit too much expanded. So you're picking a point between the two.
So generally speaking, what is the optimal? What is the optimal timing? If this case was picked up on day one.
I think when they're not quite so infanty, that when they're safely eating well, feeding well, and sort of in their first year or two. But that's just personal opinion. I take advice on it as well.
Well, I can make a little comment on that, Jeff. At the Queensland Children's Hospital, we undertake general anaesthesia in infants from basically the moment they're born, and it's a controlled and safe modality in the right tertiary referral hands. So we've only seen one teratoma in the last 28 years, and we operated on that child at 3 weeks of age. And did a very similar swinging eyelid approach with complete removal, and she's now 21 years old and got 6/9 vision.
Yeah, I agree.
So
It's very much the anaesthetist, and likewise at GOS, I'm perfectly happy to operate, really from any age, because the problem is more theirs than ours, in all truth.
exactly.
Yeah. No, thanks ever so much. And I think in the interests of time, as we're running a wee bit late, we'll probably carry on. And I'd like to call on the next team, please. When it's the team from Chennai, I think. Is it? My screen is frozen.
Jeff, we can hear you nice and clear. No problem.
Right. But yeah, we need to. I've lost my
it's
updating,
Dr.
Ron.
Monisha from Chennai.
Sure.
Thank you.
You can start your screen share.
Yeah, sorry, Senthil. You've got a better screen than I have. I froze there.
We can see you clearly. No problem.
We can see you nice and clear, Jeff. No problem.
That is the problem, probably.
Thank you everyone for this opportunity. I'm going to present a case of a challenging pediatric orbital tumor from the Department of Orbit and Oculoplasty, Regional Institute of Ophthalmology in Chennai. So a 15-year-old male presented to our OPD with complaints of protrusion of left eye for past 1 week after sustaining accidental trauma to his left eye with his fist while playing at his school. On examining his left eye, his vision was 1/60 by Snellen's chart. Tension by Goldman applanation tonometry was 20 mm of mercury. There was eccentric proptosis with downward and outward displacement and partial luxation of globe. Supralateral fullness was noted, and the extraocular movements were restricted in all directions. Lag of thalamus was present. In conjunctiva, there was prominence of episcleral vessels. Cornea was clear. Another anterior segment was normal. On examining his fundus, the media was clear. Disc margins were blurred and hyperemic. Vessels showed dilatation and tortuosity. Background retina was edematous, and macular edema was seen. Upon investigating him on day 2 of presentation, initial CT orbit revealed a hyperdense, well-defined lesion of size 4 × 3 cm in the extracorneal space of supralateral aspect of left orbit, suggestive of hematoma. And this is the preoperative picture. Because there was a rapid, unhindered progression of proptosis even after medical management in the form of IV methylprednisolone, chemosis and increased luxation of the globe was noted. So to protect the cornea and based on the CT orbit picture, we went for a lateral canthotomy with cantholysis, and aspiration of hematoma in the supralateral region was attempted, and drain was kept in the wound site for 2 days. And on day 7 of presentation, which is a post-operative day 3, there was again a rapid progression of proptosis, and so we considered that a rapidly growing tumor like rhabdomyosarcoma for a differential diagnosis workup. And on day 8 of presentation, we did an MRI which showed a T1 isointense and T2 hyperintense lesion measuring about 5.7 × 3.6 centimeter in the supralateral aspect of orbit, occupying the extracorneal and intracorneal space. And because there was variable intensity in the T1 and T2 images, and because it was also rapidly progressive, we did a CT cerebral angiogram, and this showed a vascular hyperdense lesion of size 5.5 × 3 centimeter, enhancing heterogeneously on contrast administration with no evidence of bony erosion, and this was supplied by branches of ophthalmic and superficial temporal artery, and so a possibility of highly vascular tumors such as rhabdomyosarcoma was considered. And so we refer the patient to a surgical oncologist, and true cut biopsy of the lesion was done. Histopathological examination revealed linear course of tissue showing cellular neoplasm composed of atypical spindle cells arranged in sheets. And we also did an immunohistochemistry which revealed the cells to be positive for desmin but negative for smooth muscle antigen, pan-cytokeratin antibody, S100, and epithelial membrane antigen. The diagnosis was established as spindle cell variant of embryonal rhabdomyosarcoma. On day 18, the presentation was like this, and the patient was staged to be as group 2, stage 2 category according to inter-rhabdomyosarcoma study group and TNM staging. And the tumor board advised us a multimodality treatment with the WAC regimen consisting of vincristine, actinomycin, and cyclophosphamide therapy followed by brachytherapy. So the patient is currently on brachytherapy following chemotherapy. So we can see the progression of proptosis in such a short span of time from day 1 of presentation till day 18. There was rapid growth of the tumor, and also the imaging series where we can see the size of the lesion has increased from the time of presentation. So my questions to the panelists would be like, how do we overcome the initial clinical and radiological misleading in the early stages of rhabdomyosarcoma? Also the role of multimodality in the prognosis, survival rate, and recurrence of rhabdomyosarcoma. And for an ophthalmologist, what is the role of surgery in the management of rhabdomyosarcoma? Thank you, everyone.
That's great. Thank you very much, Maria, and apologies for the poor introduction, my fault. I lost my screen for a sec. A lovely case. Usha, maybe give a comment on the various aspects that Maria has brought up about the management. I think, you know, key is the history. I mean, you gave it beautifully. This is a galloping lesion and quite clearly not a hematoma. It would be unusual to be so well defined, but often parents will present, as you know, with some sort of history of trauma which has brought it to their attention. But gosh, you had a very fast lesion there. As for surgery and so on, Usha, what do you feel, or Mylind, you know, my co-panelists?
Usha Kim, are you online?
I hope so, because she's next, I think. Okay.
Can I make a comment here?
Yeah, sure. Please do.
Okay, I read that you know, there was a Desmin that was performed in this tumor and it came out positive. However, just Desmin positivity is not enough to call a tumor a rhabdomyosarcoma. It is very important to do either a myogenin or a MyoD1 to confirm it as being a rhabdomyosarcoma, because Desmin can be positive in few other tumors as well.
Right. I wouldn't dare argue with. I'm Daniel in the lion's den when it comes to pathology. Yeah, but that's interesting. Yeah, but I mean, clearly it was a galloping tumor, and its characteristics on imaging were very much that of an aggressive tumor where it pushes everything aside. And you've got this large ovoid tumor with a history of a week or two. And that's almost certainly, in an adult, you'd think it's melanoma. Most commonly that will present in that way. In a child, you think rhabdo. Intact excision, certainly I've done that, but the actual oncologists get terribly upset because you've removed their tumor marker. That shows how it's responding to chemotherapy. So I've been told off by a rather aggressive oncologist for doing that. But I tend to try and remove most of it intact if possible.
May I ask?
Usha Kim, yeah.
My question was, why did you do a CT angio? What was the reason for the CT angio?
Ma'am, because it presented initially as hematoma, and also that in MRI, they were not able to pick up, you know.
Okay, the CT picture is not of a hematoma. It is not hyperdense. It is actually ISO, and there is a central area of necrosis inside that. So the initial CT itself was not a hematoma. And as Sir said, a pediatric population, when they say history of trauma, you should actually take it with this, because usually trauma is what sometimes, you know, gives them a thing that there is something going on in the orbit. So the trauma history may just be very trivial trauma most of the time.
Yeah,
so that
completely agree.
And can I clarify a little bit? Initially, the patient was suspected to have a hematoma, and then aspiration was attempted. And during the attempted aspiration, were you able to aspirate anything out? And did you send material that you have aspirated for cytology? If this was sent early on, maybe the disease can be picked up early on.
I'm sure you're right, Hunter. The things against that being a hematoma are, if that child had received a shiner, you know, due to a punch in the playground, there was no bruising of the lids, there was no cheek hematoma or swelling. You know, the whole thing was that brought to my attention by a knock on the eye. But I don't know whether aspiration was performed. But it was probably inappropriate, you know, in the circumstances.
Yeah. And then if the attempted aspiration was actually a dry tap, I think that should ring a bell that this is not hematoma, and then an earlier biopsy can be considered in this case.
I mean, the history just demands biopsy ASAP. I think
And then my personal experience is that not all the rhabdo can be, excised and intact. Some of the tumor, the epicenter is actually overlying the recti muscle. And in these cases, actually, for me, I just took a biopsy. I'm saying that these are not able to, resect it out.
Yeah,
not
no, I
all cases
agree.
you can
By intact, I always mean macroscopically as much intact as possible. But you're quite right if they're infiltrative. But quite often they push structures aside for quite a long time, even in the first weeks. They're just growing so fast. But,
Jeff, just briefly, Jeff, that story of the oncologists are wanting us to leave behind is complete bananas to me. Because if you're going to follow them with imaging anyhow, you'd rather follow them with imaging and see nothing than following them with imaging to see if what you've left behind is getting smaller. I've never understood that, and yet they were vociferous in their opinion. Any thoughts on that?
Yes, this all arises that the European rhabdo group want to use residual tumor at the site where it's occurring as a monitor for the response to chemotherapy, which, as you say, is a sort of nonsense. If you can remove 98% of tumor cells with no macroscopically visible tumor, then anything that appears during the chemo is not working with the chemo. But try and persuade the European group of that, and you'll give up.
Agree.
Actually, I years ago I have a case of a recurrent rhabdomyosarcoma after chemo and irradiations. So what do you advise for these cases?
Excise. I've got quite a good series of these patients with either residual tissue, and in the tissue they show some fairly abnormal, some very bizarre sort of mitoses often. But again, they're often well localized, Hunter, and you can take them out often intact again because you're picking them up relatively early. And so I've got a good handful of patients, some of who've gone beyond 20 years now.
Well, actually, I did that case. That case is actually quite localized, but then the epicenter is over the superior rectus and levator complex. So what I did for that case is that I actually excised the whole mass together with the superior and levator complex. So I'm not sure whether, but the patient has ptosis and the sling, and then
that
something
can
like
be
that.
dealt with later when the patient is alive 10 years down the line.
Yeah.
I think
Jeff,
sorry
to interrupt. I think we're running a little bit late.
Yeah, we are running late, so we'll carry
on.
Yeah. In fact, we've only had 12 minutes on 11:30. So carrying on to the next case is Dr. Swati from Madurai, I think. Is that right, Senthil? Do you agree?
Yeah.
Yes.
Swati from Madurai.
Yes, sir.
Start your screen share.
Perfect.
So
Swati.
my screen is visible, sir?
Yeah, it's visible.
Yeah, looking good.
Hello everyone, I'm Dr. Swati from Arvind Eye Hospital, Madurai. I'll be presenting a case titled Tumor or Not. A 42-year-old gentleman presented with fullness in the left supraorbital region with drooping of left upper lid and defective vision and pain in the left eye since 2 months. The past history, 1 month back he presented elsewhere with complaint of pain and fullness in left eye for 1 month duration. CT orbit was done, which showed ill-defined expansile lytic bony lesion in superolateral quadrant of left orbit. Incisional biopsy was done elsewhere, and the histopathology report was inconclusive. Hence, he was referred to our hospital on suspicion of adenoid cystic carcinoma or chondrosarcoma. On general examination, he was conscious alert, vitals were normal, there was no pallor, icterus, clubbing, pedal edema, or lymphadenopathy. Other systemic examinations were normal. The ocular examination, vision in both eyes were 60/60. There was a surgical scar below left eye lateral eyeball. There was ptosis, inferomedial dystopia in left eye, and elevation and abduction restriction was seen. This is the ocular examination. In the local examination, there was marked non-tender enlargement of left supralateral orbital bony ring. The CECT was done. It showed ill-defined lytic lesion isodense to brain, heterogeneously enhancing space-occupying lesion, and it was extending into the superolateral wall of left orbit and left frontal bone. Soft tissue component was associated with it. In size was 15 into 14 mm, and it was extending into the superolateral aspect involving superior oblique muscle and indenting the globe downward. The specks of calcification was seen. So differentials were made according to radiological and clinical findings were lacrimal gland carcinoma, Ewing sarcoma, metastasis, giant cell tumor, chondrosarcoma, or multiple myeloma. Systemic workup was done to rule out metastasis. Complete blood count was within normal limits. CT, chest, abdomen, pelvis, everything was normal. PET scan showed no metabolic activity. Now there was a diagnostic dilemma because of radiological diagnosis and clinical diagnosis both were towards malignant lesion. So we proceeded with surgery. We did superolateral orbitotomy with incisional biopsy. And the histopath report came as cholesterol granuloma. It shows, the slide showed cholesterol crystals, surrounded by foreign body cells. And there was chronic granulomatous inflammation and giant cells where the blue color cell you can see in the black circle, giant cells were seen with extravasated RBCs and blood cells were seen which are marked with yellow stars. After getting the histopathology report of cholesterol granuloma, we proceeded with complete excision of the mass with surrounding bone curettas. So in summary, 42-year-old gentleman presented with swelling and fullness in the left eye in supraorbital region with inferior dystropia and pain in the left eye. So clinically it was diagnosed as adenoid cystic carcinoma or chondrosarcoma, and radiologically it was diagnosed as Ewing sarcoma, chondrosarcoma or METS. So we proceeded with incisional biopsy and biopsy report came as a cholesterol granuloma. So we again took the patient for resurgery and we did complete excision of the mass with bone curettas. Now the discussion. Cholesterol granuloma, it's a rare entity. It was first orbital case was reported by Denning in 1902. It's more common in the Middle East, main, and most common site in the orbit is superolateral orbit, and that is the diploid of the frontal bone. Other sites are lungs, kidneys, orbits, liver, temporal and mastoid air cells, testes, and lymph node. The pathogenesis. There is a local tissue breakdown due to any cause which will cause hematoma, and this is the non-observed hematoma that will form cholesterol crystals and that will incite a foreign body reaction. It can extend into the apex of the orbit, sinuses, roof or lateral wall. CT scan show it appears as a mass which is iso to hypointense to brain, and in post-contrast images there is no enhancement of the lesion, which makes it different from the orbital neoplasm, which will enhanced on contrast imaging. In the MRI scan, it shows high signal intensity on both T1 and T2 weighted images owing to its methemoglobin component and interspersed by either septations of low signal. It is hyper-intense on fat-suppressed imaging, and there is no enhancement on gadolinium contrast imaging. So treatment, it consists of complete surgical excision of the tumor along with curettage of the surrounding orbital wall by careful drilling to prevent recurrence. Differential diagnosis, it should be differentiated from the other osteolytic region in the superolateral quadrant of the orbit like epidermoid cyst, chondroma, lacrimal gland tumor, cholesteatoma. Why this case? Here we report this case because the importance of cholesterol granuloma is there because it acts as a tumor masquerade. Clinicians need a high index of suspicion for diagnosis and appropriate management of these kind of cases. Thank you.
Thank you very much. The interesting case. That most important thing here is the very typical radiology of a triangular lytic lesion in the superotemporal part of the frontal bone, just that area out there. It's very typical for cholesterol granuloma, and the other differentials really are other lesions that expand within the diploe of that area, which are plasmacytoma in an adult and eosinophilic granuloma in children. And so really those three would come highest. It would be most unusual for lacrimal carcinoma to present with a lesion starting inside the bone. And in this gentleman, probably the most important thing was, did he give a history of trauma to there? It's often remote, a year or two beforehand. You know, in India, I would think of cricket and being hit by a cricket ball, because often there is a crack to that area, the temporal area, a year or two or even 3 years beforehand. And as you mentioned, the blood products break down with this gradual inflammatory process that seems to erode the bone. And your treatment, as you say, is curettage, and it tends to settle it down. Any other questions? I don't think there are from the floor.
Comment, Jeff. Histology showed.
Hardy.
Yeah, the histology showed deposits, which are hemosiderin deposits in the background, definitely.
Yeah, no, it's a very typical picture on the imaging. It's almost pathognomonic, and the differential, as I say, is plasmacytoma, extramedullary plasmacytoma, and the eosinophilic granuloma in the children. In that area, it just seems to arise in the bone and come out.
I thought cricket was an Englishman's game, Jeff.
Yeah, well, we had a whole cluster of them during the Wapping riots, which when there were a lot of bricks were thrown at policemen. And we saw a whole cluster of them in the policemen's heads.
All right.
A few years down the line. I think with that, probably, shall we carry on? If there are no other questions bouncing up. And I'd like to bring in Dr. Saravi from Chennai on out of Africa of interesting things. It's Dr. Yeah, lovely.
Thank you for the introduction, sir. Good afternoon, everyone.
Got the slides? Great. Thank you.
So I'll be presenting a case titled Out of Africa. A 17-year-old male presented to us with a rapidly progressive proptosis of the left eye since 2 months, along with diminution of vision. There was a sudden worsening in the symptoms in the last 48 hours. The medical history was unremarkable. Diagnosed as an idiopathic inflammatory orbital disease, the patient was treated with systemic steroids with some improvement, but the symptoms recurred after stopping the drug. On examination, the best corrected visual acuity in the left eye was 2/60 and 18 in the left eye. With an relative afferent pupillary defect, the intraocular pressure was 54 millimeters of mercury. An urgent canthotomy and cantholysis was done, which reduced the pressure to 32 millimeters of mercury. There was cross restriction of extraocular movements of the left eye with severe inferior chemosis, lag of thalamus, and inferior exposure keratopathy. There was a 13 millimeter proptosis measured in the left eye with raised retrobulbar resistance. The right eye was within normal limits. Fundus examination revealed a mild disc edema along with chorioretinal folds in the left eye. There was no regional lymphadenopathy, and the systemic examination was unremarkable. The blood counts as well as the biochemical analysis was within normal limits. The patient already had his imaging done, CT scan, 1 month prior to presentation, which showed a retroorbital intraconal irregular lesion in the orbit without any bony erosion. We requested an MRI scan, which showed increase in the size of the lesion with restricted diffusion and a very low apparent diffusion coefficient. And there was also distortion of the globe. An incision biopsy under general anesthesia was planned, and anterior orbitotomy with inferior phonacial approach was done. On histopathology, there was diffuse infiltration of immature lymphoblasts, and the tumor cells showed typical starry sky pattern. On immunohistochemistry, the tumor cells were positive for B cell markers, CMYC gene was positive, and the KI index was 100%, confirming the diagnosis of Burkitt lymphoma. The child was then referred to a pediatric oncologist. PET CT scan of the whole body revealed an abnormal FDG uptake in the sacral spinal canal involving the filum terminale externum and the sacral nerve roots, suggesting a CNS involvement. Owing to the CNS involvement, the patient was classified into Group C Burkitt lymphoma as per the FAB-LMB staging system and was started on rituximab-based LMB96 Group C chemotherapy protocol with a remarkable improvement within first week of chemotherapy. 9 cycles of high-dose chemotherapy was given in the following 4 phases: reduction, induction, consolidation, and maintenance phase. 8 months following the initial presentation, the patient has completed his chemotherapy with a 6x vision in both the eyes, and the proptosis has completely resolved. The extraocular movements are almost full, and the fundus examination shows mild disc pallor in the left eye. A repeat PET CT scan shows complete resolution of the orbital mass as well as the sacral spinal lesion. Burkitt lymphoma is a mature B-cell aggressive non-Hodgkin lymphoma which can involve multiple organs. It has 3 subtypes. The endemic subtype is seen in Africa, associated with Epstein-Barr virus, and most commonly involves the orbit. The sporadic one is seen in non-endemic areas around the world and rarely involves the orbit and adnexal. The immunodeficiency associated subtype is seen most commonly in HIV-positive patients and involves the lymph nodes, bone marrow, and the central nervous system. Burkitt lymphoma is commonly seen in younger age group, has a male preponderance, and has a rapid doubling time because of the rapid B-cell proliferation. Hence, this makes the tumor the most aggressive tumor till date. Therefore, the diagnosis is very important, which is based on the typical starry sky pattern on histopathology, immunohistochemistry positivity for B-cell markers, and KI index of more than 95%. The CMYC oncogene overexpression is characteristic and occurs most commonly due to translocation of chromosome 8 with chromosome 14. Intensive aggressive chemotherapy is the mainstay of management with a good prognosis. There is a 92% 2-year event-free survival rate and up to 80% survival rate in case of advanced Burkitt lymphoma. Radiotherapy has no role in the management. Sporadic Burkitt lymphoma with an orbital involvement is very rare, and to have a CNS involvement associated with it is even more rare. The CMYC oncogene overexpression is an important diagnostic tool, and intensive chemotherapy started early gives a better prognosis. Hence, to conclude, any rapidly progressing orbital mass in a child should raise the suspicion of a malignancy and calls for a prompt diagnosis and immediate intervention for a better survival. These are my acknowledgements. I thank you for your patience and for this wonderful opportunity.
Thank you very much, Dr. Sarabi. You know, that's a fascinating, very well presented case. And again, I think it underlines, like the earlier case with the rhabdo, that these tumors in children can be such fast doubling times. And Burkitt's, as you say, classically is regarded as the fastest growing tumor of all. But the management is beautiful and an absolutely fantastic response to the chemo. So I don't see any questions coming up from the floor. Anybody? Or from the panel?
Can I ask a couple of them?
Yeah, of course, surely.
Yeah. Hi, Surbi. That's a nice case. I just wanted to know, since this was a child and who presented with a rapidly growing orbital mass, was a peripheral smear done?
Yes, sir. Peripheral smear was done. Showed immature lymphocytes.
Okay, then you did not get onto a bone marrow instead of avoiding a biopsy?
So bone marrow biopsy was done. It showed no infiltrations.
I mean, didn't you do the bone marrow evaluation first and try to avoid the biopsy?
No, sir.
Maybe bone marrow biopsy, if it was diagnosed as being a Burkitt lymphoma, that could have helped you avoid a incision biopsy.
Probably so.
I think it's fair enough to say it would be an alternative.
And it actually came to be normal. We had done it after that, but it was actually normal. So I guess here for us, the biopsy actually helped us out.
Our lymphoma always involves, if it's easily accessible, large lesion in the orbit, we will still
absolutely
do biopsy.
Yeah, no, I think, there's no question that you'll get the pathology in the orbit, whereas the bone marrow and other sites is more open or has a higher morbidity, as in the CSF and so on. So I think a very reasonable diagnosis. The biggest problem with that sort of lesion is that they get so much chemosis after any surgery that it could be hard to manage the front of the eye. And so that just makes it more awkward for the ophthalmologist. But I think fascinating case. And I think probably in the interest of time, we'll push on to the last case, which is from Dr. Nina Mutmania from Indonesia. So look forward to it. Adults or kids? $1 million question. That's great. Thanks very much. We got the screen, which is good.
Yes.
The Dr. Rose, for the introduction. First of all, I'd like to thank Mr. Sampat, Dr. Ganga, and Dr. Senthil, and the organizer for this wonderful opportunity. Good morning, good afternoon, and good evening, doctors. My name is Mutmainnah Mahyudin from Jakarta, Indonesia, and the case I would like to present today is quite challenging. Is it an adult or pediatric tumor? A middle-aged man came to the clinic looking like this. He complained of the protruded left eye since 1 month with accompanying pain and decreased visual acuity. History of trauma is still questionable, but he was a sport trainer. There was no fever, no other significant symptoms, and no improvement despite the antibiotics given by the previous ophthalmologist. On further examination, the visual acuity of the left eye was 6-meter finger counting with slightly elevated IOP, and signs of acute process was there, and mass was palpated along the lateral orbital rim, extending from superior to the inferior side. There was RAPD and slightly hyperemic optic nerve head, and other part was fine. So at this point, no orbital imaging yet. But with the facts shown in this patient, middle-aged male, sudden onset of proptosis, pain, impaired visual acuity, positive RAPD, and other signs of acute process, what we have in mind was firstly inflammatory process, although vascular lesion, infection, or even neoplasm can still be a possible cause. We then ask for orbital CT scan, but in our setting, sometimes it cannot be done immediately due to insurance problem. So while waiting for the imaging, we proceeded with starting oral steroids for the patient. This is the orbital CT scan, and the reports from our radiologist said that there was a huge extracorneal mass with fluid level as shown in this yellow arrow, and there was destruction of posterior lateral wall of the left orbit, which is suggestive of malignant process. This result, of course, is quite surprising for us because in our mind, neoplasm is the last possible cause given the patient's clinical feature. So we revisited the case and recalled what we had so far. The onset was relatively acute. There was obvious sign of inflammation with pain, impaired visual acuity, and RAPD, but yet there were also signs of chronic process where we can see long horizontal lid fissure and long brow to upper lid margin distance. We revisited the CT scan again, and we noticed that the bone was remodeled rather than destructed, and the left orbital space was huge compared to the right side as pointed in the arrows. These features usually did not happen within 1 month, and more specifically, usually this showed a chronic process that is ongoing for years. The patient and his family insisted that he was looking normal before 1 month ago, and we then asked the patients for old photos. And these photos show that his left eyelid has always been slightly droopy with longer horizontal lid fissure. So the term normal is not necessarily have the same definition. After 1 week of oral steroid, the inflammation partially subsided, but the visual acuity remained the same. So we thought of an acute process in a chronic condition. Could it be a ruptured cyst or a ruptured lymphatic malformation? And because the lining of the lesion in the imaging is distinct, to help decompress the optic nerve, we decided to do excisional biopsy. And we did lateral orbitotomy with lid crease extension without bone removal. And intraoperatively, to our surprise, we found oily whitish yellow liquid with abundant hair, as we usually see inside a dermoid cyst that can be found in a pediatric patient. This was the suction canule that we cut open to see the hair more clearly along the milky and oily fluid. The cyst wall was not intact, but was managed to be removed. So histology from the lesion shows fibrotic tissue. At one area consists of granulation tissues that moderately infiltrated by chronic inflammatory cells and macrophages. A few material like lamellar keratin were also found, although the epithelial lining, the wall is unable to be identified. And such features can be found in ruptured dermoid cyst. This is the patient 2 weeks after surgery on the left and 1 year after surgery on the picture on the right. The visual acuity and the IOP was back to normal, and he is doing good so far. So just a brief reminder of orbital dermoid cyst. It constitutes 46% of all orbital lesion in children. It's basically normal skin appendages in normal location, which is characterized by keratinized epithelium, hair follicles, sweat, or sebaceous glands. It can be superficially located and thus early detected and managed, or it can be deep in the orbit and easily missed missed as seen in this patient. So in this case, it's a pediatric tumor in an adult. So lessons learned from this case are rupture of deep orbital dermoid cyst can be spontaneous and happen in much older patient. We need to do careful history taking and examination in every single patient with proptosis. And when in doubt, we can ask for old photos. We need to revisit the orbital imaging with patient's clinical features always in mind. So maybe questions for the panelists. I have 3 questions. The first one regarding the steroid. At initial presentation, would you consider giving steroids to reduce the inflammation regarding the positive RPD as seen in this patient? And what about giving triamcinolone acetonide intraoperatively to help further reducing the inflammation? And the third question may be, if such a deep dermoid cyst is suspected and coincidentally found in an adult, not ruptured and the orbit is quiet, should we consider excisional biopsy in such cases? Thank you.
That's great. Thanks very much, Dr. Nina. I mean, fascinating cases. And I think you've highlighted really a few things. One is that, again, we have a history of trauma, but totally irrelevant to the case, almost certainly. You also highlight how important the photograph album, what people consider normal when you look at it objectively, is often clearly shows the disease, and you showed it beautifully. These deep orbital dermoids, as you say, are so characteristic with the expansion of the bone, and they typically lie most commonly in that supratemporal quadrant and expand the bone. And the fluid level, as you say, is a giveaway. There's only one thing that looks like that with passive expansion of bone, and that is the deep dermoid. But they often are missed for years. It's coming out in ophthalmology, in fact, this month. We wrote up 82 of these patients with deep dermoids, and they often didn't present right till the 3rd, 4th decade when they start getting more inflammation, which you brought out so nicely. It's the inflammatory component, but they do get inflamed very early. And when you come to operate them, they're actually quite difficult because year upon year of inflammation has stuck them to the neighboring structures. And so they can be quite difficult to get out, but I do remove them all because eventually they do run into problems and they cause problems with increasing ptosis, motility, but very nicely managed. Preoperative steroids, useful when you have the really acute inflammatory response beforehand. And otherwise during surgery, I don't tend to use steroids, maybe a few days afterwards to reduce the inflammatory response. But you did everything right. You floated out the remaining lipid and you've removed the lining. I don't know if any of the other panel members have comments, from Mylint or Usha or Hunter.
Thank you.
Dr. Usha, do you have any comments to make?
Yeah, I'm just, can you hear me?
Yeah, we can hear you.
No, I was just asking Dr. Jeff about the question that she had raised about aspirating. If it's a deep dermoid, deep down in the orbit, would you aspirate it first and then remove the tumor in toto, or you would just want to?
No, what I tend to do, Usha, with these, the key thing is they're very characteristic. And what I do is I go down the orbital face of the lesion, trying to keep it intact for as long as possible to separate off the lateral rectus, which is often close, the orbital fat, which you will find is abnormal, but you can find the plane next to the lesion. So I try and isolate the lesion against the lateral wall. And then what I do is I raise the periosteum around the edge of the lesion because it's quite well defined in its defect in the bone, and start working towards it. And at that point, you'll almost certainly find that you get a rupture of the lesion because, of course, they're very, very thin. And so then I will aspirate out all the oil and continue to raise it from the wall of the orbit. And if there's an external component in the temporalis fossa, I'll remove that as a secondary procedure, the same operation, but just go down the outside wall and under temporalis. And that way you can generally get them out. But the key thing is to get the normal orbital tissues separated from the mass as soon as possible. And it's easier to do when the dermoid is still full and turgid, tight. But
would you inject steroids to the wound?
No, I don't, Ron. I tend to just give them about 5 days of oral steroids to reduce the acute inflammatory response. But otherwise, I wash them out, as did Dr. Nina, with a lot of saline, and you find that any spilt oil droplets float up on the saline.
Jeff, the other useful tip you always used to have is to use a probe or the stiletto of a sucker, so that once it has ruptured, you can put a probe very gently, and the end of it. It's not going to be lobulated as such.
Good point, David. Yeah, what I tend to use is the butt end of a squint hook, which is just blunt, but put it into the cavity and feel your way around so that its far limits. Yeah, absolutely. Thanks, David. Good point.
Just there's one more question regarding whether you'd remove a dermoid in an asymptomatic patient. Suppose you incidentally find the dermoid. Will you go ahead and remove it?
Yeah, unless the patient is moribund from some other reason, and it's found in their 80s. But in general, they tend to be picked up in their 30s and 40s, when you're going to expect them then to have 30 to 40 years of further lifespan. And even when you go in at that age group, Senthil, you find that they're often tightly adherent to the back of the lacrimal glands. So you warn the patient they'll lose tearing, reflex tearing, because the mass is stuck to it and you're taking out the lacrimal nerve. And they're often stuck to the neighboring orbital fat, which is often it's like candle wax. And you look at it histologically, it's got a lot of chronic inflammation.
Okay. Jeff, I found a lot of these deep ones are actually epidermoid cysts rather than true dermoid cysts, the deep ones.
It can be hard to tell, but you're quite right. They're often not as hairy as the external ones, and dermal structures. But the only thing slightly against that is that, Tim, many of them are filled with peanut oil. In other words, sebaceous oil, which implies that there are pilosebaceous units, even if you can't see the hairs. And certainly that fluid level that we saw there suggests that there was peanut oil and keratin. But that was the other thing Dr. Nina brought out, was that they couldn't find the lining. And of course, that's quite common in the specimen because it does get fairly atrophic eventually. But thanks very much. And I think probably Senthil, it's sort of up to you.
Dr. Veena, do you want to make any comments on the radiology of this lesion, how to differentiate it from the other ones?
Oncology is very typical. A fat fluid level is a dermoid. There is no differential for that.
No, I agree. It's more or less 100%. The only thing occasionally you can get is malignant transformation within a dermoid. That has been described. But otherwise, there's really no question. It's a sort of no question diagnosis. And I think probably in summarizing the session, shall I do that, Senthil?
Yeah, you can.
I think there are a few really good points that came out. One is that the history of trauma can be quite misleading, both in children and in adults. That really brought out throughout it is the rapid progression of lesions, either in the child, the two younger kids. There's no question that that's a malignant tumor till proven otherwise, whatever anybody else says. And the high Chi-67, 70% in the rhabdo, 100% in the Burkitt's, totally understandable. And the last thing is that the dermoids present late, these deep ones, but they often present with inflammatory symptoms, so they can look like dacryoadenitis, but they do need to come out because eventually they run into more and more problems with fibrosis. But I think a very useful session because they actually overlap so nicely. And thank you very much to all the speakers and to yourself, Senthil, for chairing it.
Thank you very much, Jeff. Fantastic session and very nice take-home points. I now passed on to Sampath, who will open the final session of the day.
Thank you very much. I would like to invite Santosh, Rebecca, Guy, and Bipasha to take over chairing this session, please.
Thank you, Sampath. Yeah, I invite Ganga's team. I think it's Zin who is presenting on a benign, not so benign tumor.
Hello, good afternoon from the Yangon. Can you hear me?
Yes.
Okay, so thank you, organizer, for giving me the opportunity to present a case, a not so benign tumor. A 26-year-old lady presenting with progressive prominence of the left eye for 8 years. She has a past medical history of orbitotomy with biopsy for 3 times. The first surgery was done at the age of 17 with anterior orbitotomy and excisional biopsy. The histology was neurilemoma. surgery was done at the age of 22 due to the recurrent protrusion, and debugging of the tumor was done. The histology on second time was meningioepitheliomatous type of meningioma. The third surgery was done at the age of 25, also due to the progressive protrusion. At that time, only incisional biopsy was done. The histology was myoepithelial-rich mixed tumor with a myeloid deposit. At the time of presentation, the examination of the right eye was unremarkable, and the left eye, best corrected visual acuity was no light perception, with marked conjunctival congestion with exposure keratopathy, keratinization, and vascularization. There was reverse RABD grade 4 on the left eye. The anterior segment, lens, and fundus detail cannot be assessed. Left eye was 20 millimeter proptose. So on the CT scan, there is a heterogeneously enhanced soft tissue mass involving in the intraconal as well as the extraconal, extending into the orbital apex without extending into the intracranial. At that time, our differential diagnosis were optic nerve sheath meningioma, peripheral nerve sheath tumor, neurilemoma, mesenchymal tumor of the orbit, pleomorphic adenoma of the lacrimal gland, or the malignant lacrimal gland tumor. The treatment options were lateral orbitotomy with maximum debugging or total exoneration. We did the total exoneration with lid margin. The orbital cavity was covered by direct closure of the eyelid skin. At that fourth time, the histology shows slick-like vascular spaces imparting a spindle cell presenting as a hemangiopericytomatous appearance. The spindle cell tumor with the slick-like vascular spaces. Also a network of hyalinized collagen bundles between the tumor cells. There are bumps of ovoid cells with the moderately pleomorphism, open chromatin, and inconspicuous nucleoli. The immunohistochemistry show CD34 positive. The final diagnosis was solitary fibrous tumor without malignant features. These are the pre-op and 6-month post-op photos. The landing points for this case, the solitary fibrous tumor behave as a benign tumor, but local recurrence are possible and usually after incomplete excision. Long-term follow-up is necessary. Orbital exoneration may be required even in the benign condition for complete cure. My question for the experts are challenged with the pathologist's diagnosis of solitary fibrous tumor, terminology of solitary fibrous tumor versus hemangiopericytoma, likelihood of malignant transformation with incomplete excision, residual apical lesion. Thank you so much.
Thank you so much. Very nice presentation. One of the pathologists, Kaustubh or Dr. Mudhar, can you throw some light on the confusion in pathology in this patient? Was that?
Yeah. This is a very interesting case. I mean, the histopathological features are very typical of a solitary fibrous tumor over here. The typical slit-like vessels, the ropey collagen that you see, and going forward, the difference or the confusion between the terminology. Now these two tumors are considered to be part of the same spectrum. So hemangiopericytoma is considered to be an aggressive variant, whereas a solitary fibrous tumor is considered to be a less aggressive variant. They are essentially, if you come to a diagnosis, putting under a diagnosis, I would probably call it as a solitary fibrous tumor hemangiopericytoma. That's what, a lot of people diagnose it as. But then what is more important in these cases is points of neoplastic transformation or prognostic implication, which is mitosis, necrosis, atypia. So that is what is important to look for in a report. What do you say, Dr. Mudhar?
I agree entirely, Kaustubh. One more thing to mention is that the key thing here is that CD34 is not enough. You must add a STAT6, ST86 stain, which is diagnostic for solitary fibrous tumor. There are very few entities that express STAT6, but they look nothing like SFT. And so STAT6 is really essential to make the diagnosis. Although your morphology is quite distinctive, you have the very, very typical pericellular collagenization that you saw on the histology and the peripheral collagenization. And all the biopsies from the very beginning, if you go back and stained with STAT6, I bet you they'll all be STAT6 positive. So it was SFT from the very beginning. The key thing here is the mitotic count. More than 4 mitotic figures per 10 half-hour fields, it's a malignant SFT. Less than 4 usually behaves in a more indolent way, but you've got to watch very carefully because there's no tight correlation between the histology and the behavior of the tumor. That's the key thing.
I think radiotherapy becomes important, adjuvant radiation for microscopic residual. Would any of the panelists have managed it differently? Rebecca, Bipasha, Guy, would you have managed it differently, this patient?
No, not really. I think once it's already been biopsied and it keeps recurring, there's not, and the patient's in that much discomfort, I don't think there's much else you can do, really, is there?
Bipasha, any comments?
Yeah, it's very difficult to manage a recurrent solitary fibrous tumor. The best thing is to get it out completely in the first instance. Otherwise, if they recur, it's very difficult. So,
yeah.
Is it possible to get it completely out, Santosh?
Sometimes yes, it is possible. If it's well circumscribed, if you go around it, you can dissect it if it's smaller and more anterior than posterior. But there is always a possibility of microscopic residual. So I would go by the pathologist's criteria of aggressiveness. And if it's aggressive, then I would advise adjuvant radiation.
Yeah, I agree with that, Santosh. Some of them are relatively firm and are easier to get out with an intact excision with no sharp instruments. Other ones have a more toothpaste-like contents to them and can rupture during a removal, and they're obviously more of a problem.
There was a question about radiotherapy as well. I'm not sure how helpful that would be for one that's on the more benign end of the spectrum, but does anybody want to comment on that?
If it's incompletely removed, then there is a point in doing radiation if it doesn't meet the histopathological criteria. But if it's totally removed, if you're not worried about microscopic residual having been left, then there is no point doing radiation if it doesn't meet the pathological criteria for aggressiveness or malignancy.
Yeah, I've been caught out with one that I thought was excised intact. Unfortunately, they were sent away from the clinic by a junior member, discharged. And years down the line, they came back with recurrence, and it had moved from a relatively bland, almost no mitotic figures to a more higher mitotic rate in the recurrence. The recurrence had only come on over about 6 months, and that one we excised and radiotherapy and is doing well. But the initial one had almost no mitoses and had been about 5 years before. But a mistake was that he was sent away, unfortunately. But these things happen in a busy clinic.
But do you think there would have been any benefit in doing the radiotherapy back at that stage before they had the high mitosis?
No, I think we would have kept a closer watch on him, Rebecca. Yeah. And I think one shouldn't probably discharge these patients until you've had a good, clear period, maybe 10 years.
Which MDT do you send these patients to? Ours, they are seen in the soft tissue MDT. Obviously, the lung people have a lot of experience with this. Would you follow their advice?
We have basically a head and neck MDT, Ron, so they go through the head and neck surgeons and the neurosurgeons.
Because this is soft tissue, they go to soft tissue MDT.
Yeah, no, we use the Marsden sarcoma type arrangement, soft tissue tumor, Cyril Fisher.
Yeah.
Okay, thank you so much. The next case is from Fazad's team, a case of adenoid cystic carcinoma.
Thank you, Santosh. So I would like to ask Abbas to start the next presentation of our team.
Okay, I found it. Where is my? I'm sorry.
Abbas, can you share your screen?
Okay. Just a moment, please.
During that time, Santosh, do you want to make any other comments?
You
While
can.
it uploads.
Yeah, that was a case that belonged to you. Maybe you can say something.
So the question has always been, if you have a lesion going all the way to the orbital apex, superior orbital fissure area, and there's almost always something residual left behind. But based on pathology and our medical oncology team, they refuse radiation in a benign condition. So like Mr. Rose was mentioning, we are babysitting some of these patients, waiting when this is going to explode into a malignant transformation. And that's quite stressful.
Yeah,
Has
or even
anybody
just
seen that
benign
happen
disease.
on active monitoring? Yeah.
Yeah, or even benign disease behaving aggressively.
Okay, can I start my presentation?
Yeah, sorry for delay, Abbas. Please go ahead.
Okay. Hello again. I start my another presentation, a well-known enemy and thought decision. So, okay, a 21 years old male referred for left eye ptosis since 4 months ago. The past medical history, otherwise healthy, ocular history negative, was not a smoker, and examination just confirmed the left eye ptosis. So we did a bilateral orbital CT that show the lacrimal gland tumor that extending to the apex and intraconal space. So we did the lacrimal gland incisional biopsy, that pathology report, say adenocystic carcinoma. So after the according to the pathology report, we recommended that radical surgery, but the parent refused radical surgery and excision. So we just did the globe-saving tumor removal for the patient, and in the pathology tissue sample of the total mass removal show here you can see that the trabecular bone of orbit that involved by tumoral cell, and here the perineural involvement. And here we did the IHC for tissue sample that confirmed the high proliferative tumor. So at first we start to systematic workup that show no metastasis. But after 1 month, during the physical examination, we noted for enlargement of left parotid area that we did the MRI that found the left parotid gland mass. Here you can see enhancing lesion in the left parotid gland. So we did the fine needle aspiration for parotid gland and lymph node that the pathology confirmed the tumoral cell. So this is the adenocystic carcinoma. The staging was T4BP1. So we wanted to parotidectomy, but the parent refused, also for left facial palsy. So we refer the patient for radio-oncologist, and they start the EBRT for a patient in the 30 fusion EBRT. Here you can effect of EBRT in the left of orbit. So after this 30 fusion, the patient get happy with an open, no diplopia, and the best corrected visual acuity was be normal. But after 1 year, the patient returned with the left upper lid swelling, pain for 5 days, and decrease of the vision in the left eye, and limited superproduction. So MRI again, and you can see a left extra and intraconal and extra and intraconal lesion, enhancing lesion that extended to the supraorbital fissure, and the dura and greater sphenoid bone will be involvement. So we refer a patient radiologist, and they start the re-EBRT. But the patient missed to follow up for a month. During the missed to follow up, the patient underwent the left exentration by another colleague and received the chemoradiotherapy. And when he returned with multi focal, multifocal cranial foci, and left temporal to the left temporal. Here you can see left temporal foci invasion. And after 2 months, he expired due to brain metastasis. So question to panel, how do you manage stage 4 lacrimal gland ACC in children? And do you consider either intra-arterial or systematic chemotherapy in lacrimal gland ACC? And when do you consider exentration in ACC? And thank you for your attention. And I'm so thankful to Professor Poitel. They give me a chance to be here.
Thank you so much. I think, yeah. Do you want to say something, Rebecca?
Oh, I was just going to say what a tragic case. And did the young man know at the time that he refused the exenteration that he would die if he didn't have it? Because once you got onto
that's the wrong question, Rebecca. Basically, the patient's going to die whether they have the exenteration. In fact, they're more likely to die with the exenteration.
Yeah, that's true. That's true.
You know, we've shown that quite clearly,
Yes.
and the continued use of exenteration for adenoid cystic carcinoma is totally misleading. The real key question there is, you get these terrible skull base recurrences in the cranial diploe where people open bone with adenoid cystic carcinoma. I saw a whole lot of them in the 80s and 90s. And since stopping opening bone with adenoid cystic carcinoma, I've not seen one in the 70 odd patients that we've had. And the key question really is, where was his first radiation field? Did it include the roof of the orbit, the lateral wall, the superior orbital fissure? Those areas have got to be treated in the anterior cavernous sinus. Otherwise you'll get recurrence along the skull base, as was shown.
Exactly, Jeff, because we observed the preneural invasion, we consider to irradiate SOF and cavernous sinus area and skull base.
Absolutely.
Yeah.
But did they do it?
Yeah, yeah.
Okay.
Jeff, I'm sure Sachin can come in here, because we send our base of skull to the base of skull unit in Sheffield, who provide a fantastic service. And obviously there are various schools of thought, including yours, Jeff, and from Anderson in Texas, about how best to manage these patients. And Sheffield tend to go down the surgical route. They go up to the cavernous sinus and try to take everything out. We have one patient who had recurrence of adenoid cystic, and then they did extensive radical surgery, and she's still here 7 years later, one of my patients from Leicester. So I don't know.
Wait another few years, Ron. You know, the trouble is 7 years actually isn't a great survival for adenoid cystic, even with recurrent disease. They march on for decades. They're awful disease. You know, 20 years we'll accept.
Sachin, are you there?
I think it's a big debate really, and we've got the whole range of patients, and similar. You know, we've got patients who have refused treatment and who've died. We've had patients who only had local resections and died 5 years later, but with a eye that is sort of cosmetically acceptable. And we've had patients who've got massive craniofacial resections and have died, but looking quite cosmetically damaging for the 5 years they're going to survive. So in the end, it becomes patient choice really, and it's a constant battle I have with the neurosurgeons. What is the best management for them? So there's just still no right answer. If it is already exceeded the craniofacial, if it's still in the orbit, I would want a local orbital bone sparing treatment. But the one moment it is beyond the orbit, then it becomes a patient choice. Do you want to just accept what has happened, or do you want to go for a big craniofacial resection? At that point, perhaps I would let the neurosurgeons at the skull base decide, like Sampath's case, which then has survived 7 years. Would he have survived without treatment? I don't think so. So
interestingly, though, you know, anecdotally, with microscopic involvement or even macroscopic, where you see it at surgery of the lateral wall, I've had tumor out into the temporalis fossa. If you just remove that bone without deliberately opening vast amounts of bone and then give them the radiation, they don't seem to get recurrent local disease there, Sachin. So the problem is, as you say, when it enters the cavernous sinus, what to do then? You know, they're the real devil.
this patient already had very posterior disease, didn't he? And he already had, and then soon he had a parotid node. And once it was in the parotid, he was probably right to refuse all of this extensive surgery, wasn't he? Probably.
Santosh, what's your take? How aggressively do you manage your adenoid cystic?
Right. In our situation, what has changed the prognosis is chemotherapy. Because irrespective of what surgery you do, they die of systemic metastasis, not of local tumor recurrence. Local tumor recurrence is one component which may be sometimes very difficult to manage with a conservative surgery. You might have to be radical about it, but they die because of either intracranial extension or systemic metastasis, for which unless you bring in chemotherapy as a neoadjuvant treatment and adjuvant treatment, prognosis is not going to change.
Could you publish more on that? Because it's hard to persuade
right,
RMDT
it's
to
under review.
Yeah,
And yeah, it
hard to
should see the
persuade
light of the
RMDT
day
to
soon. Yes,
MDT to do
Yes,
any
we are waiting
chemotherapy.
for the publication.
Right, yeah.
It's also worth mentioning, Santosh, that a macroscopic excision is very achievable. And since it doesn't recur at that site, it's peripherally, really you can achieve a very impressive macroscopic excision right up to the superior ophthalmic fissure with good exposure. And that, again, there is really no role for putting them through more than that, which, as you say, the outcome is defined by tissue beyond that point anyway. So unless you're going to go for a massive overkill the first time round, you're still not going to make any difference. Hence, there's just no value in these huge excisions, and I'm surprised they're still happening. They are happening in the UK still, but I'm surprised with the literature out there, it is still happening, because I don't think it should be by and large.
I would like to ask the panelists if you recommend intra-arterial chemotherapy for such cases.
Intra-arterial, actually, it can chemo reduce the tumor. It will work on the tumor, but it will not work on systemic microscopic metastasis. So if at all your aim is to reduce the tumor size to do a safer surgery, then intra-arterial is perfect. But if your aim is to take care of microscopic metastasis, then it has to be systemic chemotherapy.
A lot of these big tumors, you won't have the artery available as well, is the big problem.
Right. So let's go to the next case. Harika, you're ready?
Yes. Hello, everyone. Greetings from India. Namaste to all.
Can you share your screen?
Yes, one second.
Do you have trouble? Can we move to the next case and come back to you?
Okay, she's on.
Yeah. So I'll be discussing another interesting and a rare case today. This is a 70-year male patient who presented with a swelling in the left upper eyelid since 3 months, which was painless and gradually progressive. On examination, his best corrected visual acuity was 6/9. The pupil and the intraocular pressure was normal. The patient had an hypoglobus of 2 mm and a proptosis of 5 mm. The extraocular movements were restricted in all the gazes except inferiorly, and the patient had significant diplopia in all the gazes. On contrast-enhanced MRI, there is a soft tissue lesion in the superolateral aspect of the left orbit, which is iso-intense on both T1 and T2, with the destruction of the frontal bone with an intracranial extension to the frontal lobe. The contrast-enhanced CT scan has confirmed the erosion of both the roof and the lateral wall of the orbit, with a compression on the superior part of the globe. So with the clinical radiological evaluation, we have come to the differential diagnosis of adenoid cystic carcinoma with intracranial extension, lymphoma, plasmacytoma, and metastasis. A multi-level incision biopsy was done, and the histopathology showed the sheets of plasmatoid cells. On higher magnification, we can see plasmablast and the plasma cells. The immunohistochemistry, these cells were positive for CD138 with a characteristic membrane positivity, which was characteristic for plasma cells. CD20, CD3, PAN-CK, Desmin, SMA, BC16, and EMA were negative, and Chi labeling index was 60 to 70%. So with this, we have come to a diagnosis of left orbital plasmacytoma. So as we all know, orbital plasmacytoma is an uncommon presentation of multiple myeloma, and only 1% of orbital tumors are plasmacytomas. Plasmacytomas constitute 5 to 10% of all the plasma cell neoplasms. Orbital involvement is uncommon, and in more than half of the cases, it is only discovered after the diagnosis of multiple myeloma. Till date, only 72 cases have been reported in the literature. So we have done the systemic evaluation for multiple myeloma in our patient and all were negative. The bone marrow biopsy from the left iliac crest was negative. On PET CT scan, there is an increased uptake seen in the left orbit, the T4 transverse processes, and the humerus. The biopsy of the humerus was also suggestive for plasmacytoma. So monoclonal gammopathies are a group of disorders in association with monoclonal proliferation of the plasma cells. The International Myeloma Working Group have given a diagnostic criteria to classify these monoclonal gammopathies, multiple myeloma, and the related disorders. The plasmacytomas without multiple myeloma fall into 3 categories. Those with a single bone lesion are termed as solitary plasmacytoma of the bone. Those with single soft tissue lesions are termed as solitary extramedullary plasmacytoma. And those with multiple sites of the disease in the bone, soft tissue, or both are termed as a multiple solitary plasmacytomas. So now we have a final diagnosis of multiple solitary plasmacytoma of bone. Coming to the management options, radical radiotherapy is an excellent local disease control as the tumor is radiosensitive. There is a case study showing lower relapse rates with radiotherapy alone in comparison with the surgery and chemotherapy. There are few case reports on management of chemotherapy in such cases. Autologous stem cell transplantation has been reserved for many multiple or recurrent lesions. So our patient underwent external beam radiotherapy to the orbit, to the T4 transverse vertebrae, and to the humerus. So 6 months post radiation, clinically there was no palpable mass or tenderness. There is a resolvement of the intracranial component and the bone remodeling has started. And so we decided to closely follow up the patient with a workup for the multiple myeloma. 1 year after EBRT, the bone remodeling has increased and we have given an intralesional steroid injection to the residual component of the sphenoid vein. 6 months post injection, there is an increased bone remodeling and the PET bone scan was negative and we decided for a close follow-up. So solitary plasmacytoma of the bone shows has 10-year survival rate of 16% with 52 to 80% chances of progression to the multiple myeloma, whereas the solitary extramedullary plasmacytoma has 10-year survival rate of 70% and 10 to 44% of chances of progressing to multiple myeloma. Because of the rarity of cases of this multiple lesion, the progressing rates are really not known, but the solitary lesions definitely have a better prognosis than the multiple ones. So it has been 2 years since the presentation of our patient and he is doing extremely well. So for the prognostic markers, if there is a persistent monoclonal bands more than 1 year after radiotherapy, flow cytometry, abnormal serum-free light chains, and the genetic factors serve as a prognostic markers. However, there is no proven value in the solitary lesions for the genetic ones. There is a case report on multiple solitary plasmacytoma with an extramedullary component of the orbit. So ours is a novel case of multiple solitary plasmacytoma of the bone involving the orbit. So to conclude, systemic workup for multiple myeloma is very essential to guide the treatment and to prognosticate the disease. Detailed histopathological evaluation with immunohistochemistry is very important. The role of imaging such as PET CT should be focused on the early detection of additional or recurrent lesions which influence the clinical management. Thank you everyone for this wonderful opportunity.
Thank you, Harika.
Thank you very much. Yeah, there's a suggestion that since we're running a bit behind, that we have all the cases now and then have the discussion at the end for everybody that can stay. So shall we go on to the next case?
Sure. It's Sachin's group.
Okay.
Okay. So good afternoon and welcome to this presentation from Sheffield entitled A Silent Invader. So we present a 4 to 6 year old lady who was referred to Sheffield Oncology Services with a 1-year history of a red irritable lesion in her left eye. She also had an asymptomatic lesion in her right eye. She had no other significant findings on examination and no other relevant clinical history. Here we can see the right eye with a medial conjunctival red lesion involving bulbar conjunctiva. And in the left eye, there's a more extensive fleshy proliferous lesion involving the inferior medial conjunctiva, inferior fornix, caruncle, plica, and tarsal conjunctiva. The MDT gave a provisional diagnosis of bilateral OSSN with probable invasive disease in her left eye. She had right conjunctival map biopsies and left excision of lesion, cryotherapy, graft, and intralesional interferon. During the procedure, it was noted that the left lesion extended deep into the orbit, hence was only debulked, and full excision could not be performed. Here is the H&E stain slide from the right eye. You can see the abnormal squamous epithelial cells are confined to the epithelium, so this is carcinoma in situ. In places, the abnormal cells start to bulge into the stroma. And here in the left eye, the cancerous cells are seen to be invading the stroma in lobules with areas of some necrosis. This is invasive squamous cell carcinoma of the conjunctiva. A post-biopsy MRI shows the left SCC invading back into the orbit between the inferior and medial rectus muscles. There was no evidence of any extraocular spread. So further management was discussed at the MDT. The right eye in situ SCC was treated with a standard regime of mitomycin C. Due to the size and location of the left cancer, full excision was not possible. And while accentuation is an option in this situation, due to the presence of bilateral disease, the patient did not want this. Therefore, eye-sparing stereotactic radiosurgery was offered to the left eye using the gamma knife. A retrobulbar anesthesia was used and a frame inserted around the skull. The cobalt sources can very accurately target the tumour, and 95% of the tumour volume was mapped to be within the prescription isodose line, 50%, which equates to 18 Gray. 3 years later, there was no clinical or radiological evidence of recurrence in either eye. The only complications she developed in the left eye were mild trichiasis, which required electrolysis, and some punctal stenosis. These both occurred within the year. These post-treatment photos show good results in both eyes with a very good cosmetic result. This is the post-treatment MRI, again showing no recurrence of tumour. Orbital invasion of SCC from the conjunctiva is very rare, as in this case involvement of the fornices and the caruncle does increase the risk. Orbital invasion can extend into the brain, which can lead to death. Management of orbital invasion is usually accentuation, but this is associated with extensive post-operative complications. Squamous cell carcinoma is generally radiosensitive. External beam radiotherapy is one option, but carries a high complication rate due to the high amounts of radiation received by the surrounding tissues. Stereotactic radiosurgery is more focused, so therefore the side effects are less severe and more easily managed. It also avoids the risk for general anaesthetic in patients who are unwell. So in summary, we present a case of bilateral conjunctival squamous cell carcinoma. The left side with orbital extension, it was successfully treated with stereotactic radiosurgery. So we suggest the use of stereotactic radiosurgery for patients with localized anterior orbital invasion from well to moderately differentiated conjunctival SCC as a globe-saving procedure. Many thanks to Mr. Salvi, Mr. Bhattar and Dr. Mudhar for their help with this presentation.
Thank you so much. Do we move on to the next case then? Have discussion at the end? Okay. Then we'll go to Prachi and David's team. Invite Prachi to present. Prachi Shah.
Prachi, are you online? We did test her presentation first thing this morning. It was working. David?
I can vouch for the fact she does have a presentation because I've just checked it again.
No, we checked it this morning first.
She was updating it about an hour ago.
Can you text her or something?
I'm here. Sorry, I'm here.
Yeah.
My laptop hung. Sorry. Can you see my slides?
Yes, Prach.
Right. Hello, everyone. A big thank you
can't
to
see your slides. Sorry.
Wait, it's still loading.
Yeah.
There we go. Put it on the slideshow view, Prachi, and you're done.
Is it showing now?
Yes, but you need to start. We can see the slide, but you need to start the screen, the slideshow.
Function F5.
Slideshow mode.
Unable to reach. I'm really sorry.
Yeah, or function F5 switches it to full screen mode. Function F5.
Yeah.
How is it Mr. Rose knows everything?
Yeah, that's fine. Good.
Sorry about that. A big thank you to Mr. Sampath and the entire organizing team and all the presenters for such a knowledge-packed session. It's a great pleasure to be a part of this program. Thank you, Mr. Verity, for giving me this opportunity, and a big thank you to Professor Rose for always sharing his knowledge bank with us. My topic for today is orbital invaders. Let's begin with the first case. Here is the first case. She's a 55-year-old colleague that was referred to Moorfields earlier this year. She was referred to us with a left deep orbital lesion, which was biopsy proven to be a leiomyosarcoma. She has a very unfortunate history of multiple cancers. She had bilateral retinoblastomas, and she was recently also diagnosed with an ovarian cancer. As we see in the picture, we only see a left medial canthal fullness. And on the CT scan, we see that she has an orbital mass extending far back into the orbit. The case was discussed in various MDT meetings, and considering this was her only seeing eye, she was keen on preserving the globe for as long as possible. Patient had debulking of posterior superior orbital mass in February. She developed secondary enophthalmos with no recurrence of the posterior mass for over 6 months. However, in August this year, she noted that she developed a new nodule anteriorly, which was rapidly increasing in size in the lower lid and caruncle or the anterior orbit, which we macroscopically resected. Leiomyosarcoma is a rare tumor of the orbit, and most commonly this tumor arises as a metastasis from elsewhere. A primary leiomyosarcoma is even rarer. There have been about 3 case reports for primary orbital leiomyosarcoma. The treatment of choice would have been exenteration. However, the patient has done well 8 months into the diagnosis by debulking procedures. We managed to preserve her globe and optic nerve function to a great extent. Here are some more examples of recurrent or pervasive orbital tumors that we managed conservatively. This is a 21-year-old patient who was referred to us with a mass in the right orbital roof, which he had an excision biopsy elsewhere, and he was referred to us 3 years later with the recurrence of the tumor. It was biopsy proven to be a pleomorphic adenoma. We did a local excision for him, and along with that, we also did a ptosis correction for him. This is the picture post-operatively. Here are the scans. So he was referred to us in 2012, and the scan in 2012 suggests a tumor in the right, a mass in the right superior orbit. And this is 4 years after he had the excision. Here is another case. This is a 62-year-old patient who was referred with a pleomorphic adenoma, and she had had a resection of the pleomorphic adenoma, which further recurred 6 months later and was referred to us for a 3rd recurrence in 2012. We repeated a local resection of the tumor for her, and she preserved good visual acuity at the end of the procedure. Here are her scans. So the scan from 2012 when she was referred to us shows some proliferative mass in the left superior orbit, and in 2017, which is after we did a resection for her. This is the fourth case. Very interesting. Is a 16-year-old patient who was referred to us for an exenteration with a diagnosis of a massive orbital lipoblastoma. She already had two large lesions excised from her lung. She was presented to us with 3-month history of proptosis, which could have possibly been longer. Here are her MRI scans when she was referred to us. She had a mass in the left orbit in the superomedial aspect, abutting the globe. And if we see the axial scan, it goes all the way to the back of the orbit. This is her July 2012. We macroscopically resected the intact lesion, and along with that, we also resected the abnormal conjunctiva. Postoperatively, her visual acuity was 6/6, but marked transient apex syndrome. This is her imaging 5 months after the surgery. So if we compare the preoperative images on the right side of the slide compared to the images 5 months into the surgery, she was doing very well. The lesion had been removed completely, and there were no signs of it coming back. However, unfortunately, it came back again, and we did another resection for her. It came back along the biopsy track, and she had another resection in 2013 and a third recurrence resection from above the levator. 11 months after the resection of the first tumor, we see that she has fairly good extraocular movements, and she continued to have good visual acuity. 2 further nodules resected intact, and then no recurrence since 2015 up till now. The lessons that we learned from these cases is that locally recurrent tumors can be managed conservatively by meticulous intact resection of these masses. It helps us to buy some time. Careful dissection with no sharp handling of the tumors to prevent cell spillage. And any breach of the pseudocapsule should be treated with diathermy to seal it with non-viable cells. And superglue can also be used to seal the breached capsule until we finish the resection. The principles for this kind of management are that we need to contain the local disease whilst trying to preserve the function for as long as we can, to avoid worsening of prognosis by spreading of tumor, and to not sabotage future exenteration if needed. So avoid opening the periosteum to help later exenteration, and avoid opening the bone to prevent seeding. Take-home message is exenteration is often considered essential for massive primary orbital tumors, even when benign, or for multiple localized recurrences. We have shown that useful time and function can be gained by meticulous local resection of these masses, and thereby reducing the tumor load without sabotaging the ability to perform, if required, an exenteration at a later date. Thank you once again, Mr. Verity and Professor Rose, for helping me out with this presentation.
Thank you, Prachi. Very
Thank you
nice
very much.
set of cases. Yeah. Shall we move on to the next one by Sampath's team?
Yeah. Hello. Yeah.
Hello, everyone. My name's Dasha Khan, one of the junior doctors in ophthalmology. So I'll be presenting our case with Miss Okafor and Mr. Sampath. So the title is An Unexpected, Undesirable Visitor. So a 34-year-old gentleman, he presented with a 3-week history of swelling and ptosis of the right upper eyelid. He did not have any past medical history or ocular history or take any regular medications. There was no precipitating trauma or any associated upper respiratory symptoms. So on presentation, he reported pain and intermittent double vision, which worsened on ocular movements. So this lasted for a day during this 3-week period. So on examination, there was right upper eyelid swelling and mild proptosis. So the X-ophthalmometer readings were 19 millimeters for the right eye and 18 for the left eye. There was superior subconjunctival hemorrhage and conjunctival hyperemia. The vision was 0.22 for the right and 0 for the left. The colour vision was 15 out of 17. The intraocular pressures were 16 for both eyes, and there was no evidence of RAPD. So what happened? So we did an initial CT scan of the orbits. This showed Lincoln had done an initial CT scan of the orbits, and this had shown a right superior rectus muscle lesion. So this was interpreted as an abscess. So he was commenced on clarithromycin 500 milligrams twice a day due to the allergy of penicillin, and he had high dose steroids. So the initial diagnosis, they were thinking myositis. After 1 week, there was no improvement in the right upper eyelid swelling. Then he reported episodes of vomiting, which was associated with worsening right-sided headache, especially when lying flat. Now, on examination, he had diplopia on looking up and to the right. Vision was 0.32 for the right. The colour vision was 16 out of 17, and the pressure was 17 for the right. So at this point, MRI of the orbits was done. So on the next slide, I've actually put this MRI scan. So here, this is an MRI T1 weighted. So this shows coronal slice through the right eye. So we can see here that there's an enlarged superior rectus complex. So he was then reviewed by the ocular plastic team in Leicester. So it was evident that he had right upper lid swelling and complete ptosis with a non-axial proptosis. The readings at this stage was 22 millimeters for the right, the visual acuity was 0.7, and the colour vision had reduced to 9 out of 17 on the Ishihara plate. So an urgent orbital biopsy was done through an upper lid transcutaneous skin crease approach. So you have to bear in mind, this was done during the peak of the pandemic, and this was carried out under GA. The next day, the patient reported symptoms of breathlessness and a cough. So when listening to his chest, there were fine crepitations. So we were thinking possible lower respiratory tract infection, and we had to think of COVID as well. So we started him on doxycycline and meropenem, and we did a chest x-ray, which showed abnormal findings. The radiological differentials that we had to think of were COVID, non-COVID infections, and malignancy. Test had showed no bloodborne viruses, and the swab was COVID-19 negative. Then, on systemic clinical examination, there was a firm, painless swelling of the right testicle, and on the chest x-ray, we could see evidently cannon-bore metastases. A CT scan of the whole body was done, which showed disseminated metastatic disease. Ultrasound of the testes had shown bilateral testicular solid tumours. The right one was completely replaced by the tumour. So this was likely the source of the primary. Immediately, we referred to the acute oncology team, and they established that the patient had a beta HCG level of more than 400,000 and an LDH of 1158. The histopathology of the orbital biopsy showed features of a metastatic choriocarcinoma with no features of other germ cell components. So on the next slide, I've put the histopathology slide. So the histology of incisional biopsy of the muscle had shown metastatic choriocarcinoma to the orbit. So it was positive for the cytokeratins, beta HCG, and the GATA3. So in view of the histopathology, the patient was started on intense chemotherapy. So to give a general background, the neoplasms of the testes constitute 1% of all malignant tumours in men, and it commonly affects younger age groups. So testicular cancers, you can split them into two groups, germ cell and non-germ cell tumours. So of the germ cell tumours, around 95%, you can split them into seminoma and non-seminomatous germ cell tumours, with choriocarcinoma being the rarest and the most aggressive form. So in males choriocarcinomas, they're typically mixed germ cell in origin. It's important to note, testicular choriocarcinoma is a rare cause of metastases to the ocular components. So we did a review of the literature and we found a handful of cases, mostly with choroidal metastases. And an example here is a paper by Mohammed El-Malla. So a patient who was 21 years old presented with a 10-centimeter testicular tumor. On ophthalmic examination, they had found a choroidal lesion in the left eye, and the lesion had extended into the macula. So he was started on chemo, and 6 weeks after this chemo, the choroidal lesion had resolved. And when a follow-up was done 8 months later from the onset of presentation, there was no recurrence of the choroidal metastases. Thank you for listening.
Thank you so much. Can we have some discussion now? Do we have time?
Yeah. Yes, we have. I think what it is basically panelists and delegates who want to stay on, you're welcome to stay on. We will definitely finish by 1:30 for the ones who want to stay. Yes, we can have discussion. Ganga, do you want to take over at this stage?
No, I think Santosh, maybe since the last 3 cases we didn't have a discussion, would you like to discuss pertinent points, and then we'll go on to a final discussion of the entire webinar.
Right. So about plasmacytoma, is there any point that you want to discuss?
I think the nice thing about the plasmacytoma, Santosh, is that it showed the triangle sign within the frontal bone again, you know, like the cholesterol granuloma, but gone much further. So it's very nicely in this webinar, you've seen 2 examples of that really very characteristic sign. So very nice from that point of view. Right.
And the logic for giving intralesional steroid is that because plasmacytoma has interleukin-6 mediated osteoclastogenesis. That means that there is increased bone destruction, and that is counteracted by steroid injection. So that promotes osteogenesis and barrier formation or regrowth of the lost orbital roof. That is the reason why steroid is injected. Otherwise, the treatment of choice is radiation. You wait after a while after radiation. If there is incomplete bone remodeling, then you give intralesional steroids. Any other question on that? So can we move on to the next one? Conservative management of recurrent orbital tumors. Any comments on that? Sachin?
No, sorry, can you hear me, Santosh?
Yeah.
Yeah. So what we initially were thinking is that radiotherapy is purely a palliative treatment to try and, you know, exenteration is the treatment of choice, surgical treatment, and anything else. And when you discuss at MDTs or big skull base head and neck MDTs, the thought is, oh, anything else you do is palliative. You know, have you consented? Is the patient agreeable to this? Because you can't guarantee tumor is out until you've excised it. And what we're finding is that increasingly this multimodality treatment, especially with adjuvant stereotactic or IMRT treatments, proton beams, and hopefully once we get more evidence about adjuvant chemotherapies, we're finding that we're using less and less aggressive surgeries. I mean, I hate it, but I do probably around 30 to 40 exenterations a year still. And I really would like to come down to a point where it's just, you know, for the last 1 or 2 effective patients or necessary patients. And hopefully all these supportive alternative treatment options we are coming through with, perhaps even immunotherapies, we'll be seeing less and less of those.
I'd just like to make a comment. We had a patient with Muir-Torre syndrome. Hardeep will remember this guy who had a sebaceous gland carcinoma upper lid. The patient also had a second opinion from Sachin. He developed another lesion in the supromedial orbit, turned out to be a squamous cell carcinoma. So the choice was exenteration or radiotherapy. But he had a complete surgical excision from the orbit, which I wasn't sure it was completely excised. But the patient insisted that he will not have anything done, nor radiotherapy, nor exenteration. So Sachin also had a look, and we we gave into the patient, and it's now 3 or 4 years down the line since that, and he's still here, no recurrence, and he's doing fine. Any comments, Sachin and Hardeep?
I think we seem to be nearly having cracked squamous cell carcinoma, is my gut feeling, especially if cemiplimab comes true. Then I think that seems to be one of the cancers we are on top of. Hopefully we'll get on to something which will help SGCs next, and hopefully the massively aggressive BCCs. But squamous cell carcinomas, we're getting increasingly comfortable treating non-supra-exenteration, non-exenteration way.
Can I ask a
Could you
question,
emphasize a
Sachin?
little bit more on that, Sachin, on the targeted therapy for squamous cell, the drug, the history, and the indications?
So would anyone else like to take that question about cemiplimab?
Go ahead, go ahead.
You go ahead.
Santosh, okay. So it's only recently been NICE approved for us. So Royal Marsden has a large series of use of SCCs in head and neck cancers, head and neck SCCs. We've received, there's a cancer trust fund in UK, so we have to be very selective about what cases we use it in. So it's mainly used in patients with currently non-surgically resectable SCCs. And what we are finding, it's a very easy dose, and the cost is also much less than it was with vismodegib. I'm not very sort of 100% sure about the exact pathway. I think Santosh might have more, more of, some exact mechanism of how it works. But it seems to be giving us excellent responses, and very, very quick. Within a few weeks, we started seeing results now of patients having tumor size regressing.
Could you name the drug? And I'm going to request Dr. David Verity, who has a beautiful presentation on targeted therapies for various things, to give us an overview of targeted therapy for eyelid, lacrimal, and orbital neoplasms. David?
Sounds like you've just volunteered me for something. I need to go and do some more homework. After a certain amount of homework, it's a qualified yes.
Thank you. Go ahead, please. Yeah, educate us, please. The role of targeted therapies in eyelid, lacrimal, and orbital neoplasms, and the spectrum for SACs versus BCCs.
That's his hour-long lecture.
I think we'll have to leave that for another day. I think.
Go through the cases still, a couple more. Yeah.
Yeah.
It's
Okay.
a PD-1 inhibitor.
Ganga, I would like to say that just recently, just a few months ago, FDA approved using Kitodra for head and neck SCC. Locally advanced SCC. So it's quite promising. And, it has been shown that PD-1 and PD-L1 are targets for target therapy in SCC and the sebaceous cell carcinoma. And
What's Kitodra the brand name of? Is that another, that's another PD-1?
It's pembrolizumab.
Oh, pembrolizumab, yes.
Yeah. And it has been shown quite promising in the first reports, and one clinical trial that's published 2 years ago that's shown actually significantly more patients could survive after taking Kitodra.
On that point, can I also say we've just submitted a case report really of a patient who had a skin SCC involving the eyelid extending into the orbit after PUVA therapy for psoriasis, many years after PUVA therapy. And he was treated with acitretin, and we have amazing results where within a year, the whole tumor just melted away radiologically and even on biopsy. But then the acitretin had to be stopped, and then he's now redeveloped an in situ SCC at the site. So that's what I mean. We're nearly very close with SCC medical management. It seems to be responding well to multiple systemic drugs, and hopefully
what's the mechanism of acitretin on an SCC then?
It's known to have there are lots of published reports in facial SCCs of how it works. Again, I'm not very clued on about the exact mechanism, but there are definite publication, but none in the eyelid or orbit. So ours was actually invading into the orbit, and it regressed clinically and radiologically. So watch the space.
It's in dermatological literature. It's given specifically for patients with xeroderma pigmentosum who develop multiple squamous cell carcinomas on the face and exposed areas, it's one of the forms of treatment.
Thank you. Can I ask a question about the stereotactic radiosurgery? This might be a silly question, but given that we've discussed that vismodegib is very expensive and may not be easily available, is there any role for stereotactic treatment in the orbital invasion with BCCs? Or does it only work on faster multiplying tumors?
Oh God, no. SCCs SRS we use for lots of indications. I mean, we've got great results even with keratocaverous fistulas and every possible tumor indication treatments. So yes, it is possible. I think we just have to be mindful that the wider the area, whichever radiation you do, you're going to get collateral side effects. But clearly, I mean, I think Santosh uses a lot of IMRT rather than, proton beam or so any modality, as long as we get the 60 gray, we just have to alter the radiotherapy dose. It would work. Yeah,
because we only have IMRT. Well, there is stereotactic radiosurgery, but it's hard to persuade our radiotherapists to use it for our patients. But so do you think that the side effects are less with the stereotactic than the IMRT on the whole?
Yeah, I think you really have to be, so there are two different types. One is the single shot gamma knife, which is what we use. And what we find is that they work very well for aggressive tumors. You want to really kick and give a punch to the jaw. So a single shot works very well in that. There's some ones such as lymphoma, which you want to really slow cook, and then perhaps IMRT would work better in those. So you have to sort of just vary them and look at what.
Right. Can we move on very quickly? Any comments regarding the Moofield's presentation on myelosarcoma? Myelosarcoma, sorry. Leiomyosarcoma.
It's end of the day.
Korea's hungry.
Sampath is hungry, clearly.
Just a comment about that case, and that is that soft tissue sarcomas, of course, are one of the commonest tumors to occur in patients who have got, hereditary types of retinoblastoma. So always worth looking out for, especially in this case, which I gather was irradiated. Is that right?
Yeah.
Yes, he was irradiated.
She received radiation in childhood, in infancy. And I mean, really, the principle here that we were trying to address was that you may contain the disease locally without sabotaging long-term management. And she was quite clear, she's a doctor, she was quite clear that she wants to retain her eye as long as possible. She knows it may influence the outcome, but might not. And the other patients likewise trying to contain local disease by local management.
Jeff, worth making the point, we didn't have much time, is that the local MDT had strongly suggested that she had a surgical approach to this. Well, I mean,
in fact, a
exenteration. A hemiphasectomy, which would have left her,
and it would have been no function and no quality of life.
So I think just in this group and everybody listening, it's worth, we have to take the advice of the MDT, but at the end of the day, it's the person treating the patient that ultimately bears responsibility. And I think MDT is the patient. And I think that if you simply follow the MDT's advice without thinking, there are times that you won't do your patient the best service. And I think that was just to make a point in this.
Yeah.
But having said that, there are medical and medical-legal considerations. So when you go do something against an MDT, and that's where this collaborative network that we have globally, talking to experts, some documentation, early publications, will probably justify some of the things that we want to do for our patients to make them live better, see better, look better.
Right. Okay. I'll just make a quick comment on the Leicester patient, and then I would like Jeff to give an overall picture of what we discussed or the whole of the webinar. The Leicester patient was referred to us with a large superior rectus lesion. At that point, we thought it was either mainly rhabdomyosarcoma, given his relatively young, superior orbit, and large superior rectus. So we did an urgent biopsy on the day he was referred based on the picture it was sent. And lo and behold, it came back as what you saw. So initial diagnosis was possibly a malignancy in the superior orbit. Any comments, Jeff, and the rest?
No, I think that Ron brings out the very point, one of the many points coming from the meeting, you know, and just running through them. I think the first thing is that history is so important, was really brought out. And when the history goes against what the radiologist says, just bear in mind that you're dealing with the patient and may well be getting it right. The other thing is certain things like the typical radiology appearance that we've had on several of the lesions, like the dermoid is really almost pathognomonic. The triangle signs of aggressive lacrimal gland malignancies and the supratemporal frontal bone, again, can be big leaders from the clinical point of view and the radiological point of view. I think Hardeep and the other pathologists will agree that when you get multiple types of pathology reported over several years of lesions being excised, bear in mind, was the original diagnosis correct? Is the current diagnosis correct? Or has the lesion truly changed? So if necessary, get a better biopsy or more in the core of the lesion. Another area I think that's come out markedly from this is the effect of microinvasion from relatively so-called benign diseases like hemangiopericytoma, solitary fibrous tumor, adenoid cystic carcinoma, squamous carcinoma, sebaceous carcinoma. It's often not the macro lesion that is the problem. It's the microscopic effect, and it's treatment. And I think there, again, you brought out that many of the treatments are changing over the years, more use of radiotherapy beyond the area of the macro tumor, and the biological agents which will help mop up systemic disease, and chemotherapy, you know, as has been brought out by Santosh with the lacrimal carcinoma. So I think overall the meeting actually ties together extremely well. And I'd like to thank, you know, all the organizers and the speakers for bringing a really interesting collection of cases together, and to our specialist colleagues, pathology and radiology. And so over to you again, Ron. Thank you.
Ganga, do you want to take over the discussion?
Yeah, thank you. And I really wanted to thank everybody who start to finish, including Senthil and Sampath, who put all the brains together to make this happen. So I have a few questions for a few more people who have, some of them not spoken yet. So I'm going to start off with Veena Norona, our radiologist, probably the only radiologist in the crowd, to pick her brain and tell us a little bit about fetal imaging in orbital diseases. Where are we at? Is it being picked enough by routine ultrasound? Do sonologists look for it? And number two, the value of DCG versus CT DCG in routine versus complicated NLDOs. Veena? If she's still there. Well, if Veena's left, I have some questions for our pathology colleagues, Derek, Kaustubh, and Hardeep. Thanks a lot for staying back. Can you share with us, based on the cases that we've discussed and presented, what will be your take-home points for us as orbital surgeons, as clinicians, and how we should change our approach to these patient specimens, biopsies? We never touched on needle biopsies here, but could you tell us a little bit more about it? Derek?
Veena is still on, so.
But she hasn't responded, but.
I think the key thing is, I would say communication between the pathologist and your clinician. That, you know, to have a close interaction is so important, especially when it comes to, you know, complex surgery, complex procedures. To be given the heads up to know what to expect in the path lab is so important. You know, in Sheffield, we have a great system where the clinicians come up to the laboratory, have a look at the macro specimen if it's very complicated. They advise me on which margins are important. I'll often ask them to look at a specimen under a microscope with me as well. And that interaction is so powerful, and it really avoids pitfalls and medical legal issues. It really, really does. So important. As far as the needle biopsies are concerned, we don't do any FNAs of orbital biopsies in Sheffield routinely, except in situations where the patient's moribund, and the question is whether it's a lymphoma or non-lymphoma, where radiotherapy or other therapies could help, you know, palliate the patient. So we don't do FNAs of orbital lesions in Sheffield. So that's my take-home message is, you know, sort of communication. There's one more question from Raghavan. That was, you know, how should lymphoma specimens be sent up to pathology? The key thing is that every path lab would have hematopathologists who do things in a certain way. And the two schools of thought are send your lymphoma up fresh, unfixed to the path lab, or in formalin. Now, either strategy works very well. Those who receive fresh tissue tend to have a flow cytometer in the laboratory, and where flow cytometry is quite a powerful way of making the initial sort of diagnosis before the histopathology. So I would say any approach is fine as long as you're complying to your hematopathology SOP in your personal laboratory. That's absolutely fine. So that's my sort of take-home little messages there.
Right. Derek, would you like to make a comment?
Well, I can't agree anymore to what Hardeep has mentioned. Communication is definitely important, but let me just throw in one more person to communicate with, and that'll be the radiologist as well. So I think often the radiologist also has got quite a big clue on what the diagnosis is, and I think pathological clinical correlation in that instance is very important. As regarding needle biopsies, I think it will depend on the institution, and I think Dr. Ganga will probably be aware that right where we are, we have some pretty good cytopathologists who can diagnose quite a lot of things quite accurately. I think we have guys over here who can diagnose even like SFTs on needle biopsies. So I guess that would depend on the experience of your personnel in the hospital.
Yeah, I think with the cell block especially, we are able to diagnose more and more lesions with needle biopsies. It's not just
generally
a cytology,
in UK,
but true
I wouldn't say the
histopathology with cell
pathologists
blocks.
are underexposed or underexperienced. Hardeep is a fantastic pathologist, provides a great service for our orbital service. And generally in UK, needle biopsy is not a done thing for orbits. Hardeep?
Yeah, you're right. That's up to you guys. If you guys want to do needle biopsies, that's no problem. But as you say, as Ganga said, cell blocking is very good because it allows you to do immunohistochemistry as well as other molecular tests to confirm your diagnosis. So yeah.
Could you just explain the difference between cell blocking and normal and another FNA?
Well, okay. So cell blocking is how you handle the FNA after taking the FNA. So the FNA is going to put your cells into suspension of fixative, which is often methanol based. So you can do a cytospin where you take a small amount of that particular fluid with the suspended cells, and then a cytospin will spin down a proportion of the cell suspension in order to make a diagnosis. That's one way. Number two is liquid-based cytology, where you allow the cells to settle onto a membrane, which can then assess for morphology. We use cell blocking, where we simply spin all the cells in suspension down into a small cell pellet and handle that as a histopathology section. So you then section through the pellet as if you do a conventional histopathology paraffin section, and that's quite powerful because then you can get more morphology, better morphology, I think, in my view, tissue for immunohistochemistry on a bulk bit of tissue, and of course then you can do molecular biology for clinality and other molecular markers for diagnosis and prognosis.
I now have a question for lacrimal cases. All of us do see patients with tearing, suspected NLDOs. We do DCRs, external endoscopic. When and how should we be doing DCGs for our routine and not so routine tearing patient with suspected NLDO? Is Mr. Rose here? Because David, go ahead.
Well,
and Javed also, yeah.
I've always felt to a degree that, that you do a lot of imaging when you start your career, and as you go through, you do less and less and less. And I think that personally, DCGs are a roadmap, but they really tell you nothing about the functionality of it. And I certainly think that a really good syringing, listening to the history and seeing what comes out of the sac with gentle pressure will tell you if there's a sump syndrome left behind. And I would truthfully say I very rarely do a DCG, except if I need a bit of radiology that might convince a patient that they need some sort of redo procedure, which is very rare, of course. So personally, DCGs very rarely, DSGs more frequently. But if you really want to do a DCG, you might want to combine it with a CT, to do a CT DCG with really complicated cases. But how often do I do a DCG? Once every 6 months, probably.
Any other?
I don't know what the others think.
Is Javed still here? If not, is Lakshmi here? Or Veena, tell us about CT DCG, and when would you say tell the clinician not necessary versus this is how you should do it?
Veena is online, but I don't know whether she's going to come on.
Okay, then I will probably move on. And we had a bunch of cases which were like tumors, but not tumors, fungal granulomas, cholesterol granulomas, and dermoids, which dermoids are not really tumors. But maybe could I request Santosh to tell us if you had a patient where you suspected a typical adenoid cystic carcinoma, I know the frontiers are still very gray for a lot of us. How would you approach diagnosis and manage for a typical suspected adenoid cystic carcinoma, evidence-based? Yeah.
Well, if it is suspected and if you don't know what it is, then you have to prove it, right? So either excisional biopsy, if it's a well circumscribed lesion, which is not infiltrating the lateral rectus bone and superior rectus LPS complex, then I would completely want to remove it at the primary surgery itself and along with the investing periosteum. So it's en bloc resection. But if it's infiltrative and you cannot remove it completely without causing functional damage to the eye and ocular motility, then I would do a transseptal incisional biopsy by a direct incision right on top of the tumor. If you do a lid crease approach or if you do a remote incision, then the chance of seeding of the dissection planes is very high and planning radiation postoperatively becomes very difficult. We have had occasions where patients have recurred with tumors in the plane of prior biopsy, not in the area where the tumor was. So that's the first step, establishing the diagnosis. And if you have completely resected it or nearly totally resected it, still you have to give radiation, extended field radiation, not just to the entire extent of the preoperative extent of the tumor, but to temporal fossa, superior orbital fissure, anterior cavernous sinus, inferior orbital fissure. We even give about 10 millimeter margin beyond the extent of the tumor. That's extended field radiation and chemotherapy, of course, systemic chemotherapy.
And that's cisplatin and 5FU, or is it something else?
That's right. Paclitaxel and 5FU or cisplatin and 5.
6 cycles, I assume.
That's right.
Right. So the temporal fossa, are you able to, we are some, like Rebecca was talking about, sometimes we have difficulty convincing a radiation oncology such an extensive wide radiation. So any tips for us on how we can negotiate with them?
Well, I think the extended field radiation is published. It's not something new that, so possibly a discussion with them may help.
Okay, thank you. Thank you. And there was a nice case of inverted papillomas, and my take-home message from working with my ENT colleagues, we work with them a lot for a lot of cases, lacrimal cases and orbital cases, is that if it is only an inverted papilloma, no evidence of malignancy, we withhold radiation even no matter how recurrent it is. And surgery is the only way to go. But because it predisposes to malignancy, but once you have a malignancy, then the role of surgery or radical surgery alone, it becomes very limited. And Veena pointed out early radiological signs of infiltration. Then the management is going to be something very different. Veena's back. Do you want to answer any of these questions before I pose other questions?
Sorry, I just got caught up with some work.
Quick questions for you. Where are we in terms of fetal imaging of congenital orbital pathologies?
Yeah,
Incidental findings. Yeah.
I don't do much of fetal ultrasound and all, but then definitely there is a role, ultrasound as well as fetal MRI.
And what is the pickup rate, and how, if something is picked up, how do you recommend following up? Yeah.
Well, I'm not an authority in that. I don't do fetal imaging at all.
All right, thank you. I'm over to you, Sampath and Senthil, and rest of the panelists for questions.
I just would like to request Cornelius Rene to make a few comments on share his experience on the cases we have discussed. Cornelius.
There he is.
Yeah, I'm still here. Yeah, very interesting cases. Thanks ever so much to you, Raghavan, and the other organizers for putting the meeting together. Well, they've all been great cases with good take-home messages. And even for an old bod like me, I've learned something. So that says a lot. So thank you very much. I don't have any specific sort of comments because I think most other panelists have already shared their expertise, and I don't really have too much specific to add other than to say it's been a great meeting. So thank you.
Ganga, can I make a comment? For
yes, Prasad, of course.
Actually, you pointed a very interesting and challenging issue about using radiotherapy in cases with inverted papilloma. So some believe that doing radiotherapy, as you said, can enhance the transformation to malignant, SCC. But we have several reports and reviews that have shown, although they are quite limited, but have shown that radiotherapy is quite valuable in cases, you know, as adjuvant therapy after resection of the tumor, especially in those areas that you cannot address enough and remove tissue enough, like anterior part of the maxillary sinus, PPA, foramen oval, or, you know, the orbit. So we used to use radiotherapy for a couple of years when I was working with other colleagues in maxillofacial, ENT, and oncoradiotherapy to use radiotherapy for these cases. So I know this is a debate, but you know it's not quite definite answer for using or not using radiotherapy for IP. And I may add that now we have some clues that which IP bears some nidus of SCC based on the MRI. So you know we have kind of cerebellar formation on the MRI, T1 with GAD, with fat suppression, or T2 with fat suppression with the steer. You can have band, dark and light bands on the MRI. It shows you have, like you see in the endoscopic examination of these cases, this is IP. But when you have a solid sheet with no enhancing, no more cerebellar form pattern MRI, it shows you have transformed into SCC. So it's a marker because, you know, sometimes the mass is quite wide and in just one part you have SCC, and this is the same part that you may get hurt from, you know, growing up that colony of the SCC. So I wanted to make comment on SCC, and although I have done a lot of cases with inverted papilloma, but this was a very, very bad case that I wanted to share with you.
Tim Sullivan from
There's
Australia.
only one thing I've learned from IPs is the first time is the best time. If you don't get it out the very first time, managing any recurrent IP is always a nightmare. Go ahead, Sampath. Yeah.
Tim, do you want to make any comments on the management of the cases we have discussed?
He's with his glass of wine or champagne.
No, he's still online.
I think he's had the best idea out of all of us.
All right. On that note, I would like to say thank you to all the panelists and the delegates for making to this meeting and for the contribution, especially many of the Gen Next juniors who presented. And my special thanks to Ganga and Sendil for making this meeting happen. Sendil, do you have a few words to say? Thank to all. Thank you.
Yeah. Thank you, Sampath. I take this opportunity to thank all the presenters and the supervisors, the panelists who have made this session very interesting, very interactive, and who have sacrificed the Sunday to be here with us. And it's always a great source of inspiration and motivation to have giants like Professor Jeff Rose and Dr. Santosh Shunawar to be with us and to share the expertise. And it has been a really wonderful learning experience for all of us and all the juniors as well. And I'll also like to thank all the attendees on YouTube and Zoom, and my co-organizers, the brain behind the meeting, Dr. Sampath, who in the midst of his extremely busy schedule, 9 to 9 work schedule, has managed to put this meeting together. Dr. Ganga from Singapore, who has been supporting us with his very valuable inputs, who is instrumental in putting the whole program, giving all these interesting titles and roping in all the fantastic faculty from Asia Pacific. Thank you, Dr. Ganga. And once again, I'd like to thank all the participants and all the senior faculty members who have made this meeting very interesting. And we have so many messages on Zoom thanking all the faculty members for such a wonderful learning experience. Thank you once and all, and we're looking forward to meeting you for our next meeting. Thank you.
Hope you all have whatever is left of the weekend. And I know in UK, tomorrow is a bank holiday for us, so it's an extended weekend. Once again, thank you all, and special thanks to Sendil and Ganga, and to all who took part and contributed and made the sessions extremely interesting. Thank you once again.
Thanks all again.
Bye-bye.
We'll stay in touch.
Bye.
Bye-bye.
Cheerio. Thanks, everybody.
Itu kita kelihatan ya